Good morning, everybody. Thanks for in vain. I am Vinicio Rizza, a surgeon of Maria Santissimo dello Splendore Hospital in Giulianova, Italy. Adrian van Spiegel described the similar line in 1645, but Joseph Kinklosh in 1764 defined the spigelian hernia as a defect in the similar line. Defects in the aponeurosis of transverse abdominal muscle have been considered as the principal etiologic factor. The aponeurosis of transverse abdominal muscle is limited by the similaris line laterally and the lateral edge of the rectus muscle medially. This type of hernia represents about 1.5% of hernia formation cases of the abdominal wall and can be a congenital or acquired defect in the spigelian aponeurosis. It is much less common than inguinal or femoral hernias. The principal symptom is the abdominal pain. Diagnosis often results misunderstood. In case of uncertain imaging, the laparoscopic approach is necessary to diagnosis and the treatment. In our case, the abdominal objective examination showed only a small tumor to the left abdominal flank of unclear nature, aching with a diameter inferior to 5 mm, not reducible in abdominal cavity. Abdominal TC was performed without contrast medium to study the abdominal wall. The TC report was negative for abdominal hernias. In according to the literature, we performed a laparoscopic approach with one 12 mm umbilical trocar, one 5 mm trocar in right iliac fossa, and 5 mm trocars in hypogastric region. Laparoscopic exploration showed a little peritoneal depression to the anterior abdominal wall, adjacent left semilunar line, absence of an evident hernia ring. Because during general anesthesia, the external palpatory exploration showed a small parietal defect in correspondence of peritoneal depression, we laparoscopically opened the anterior peritoneum near the present defect. The opened peritoneum showed the extraperitoneal and interparietal fatty tissue passing through the transversus and springed out beneath the intact aponeurosis of the external oblique muscle. The hernia ring had a diameter less than 5 mm in the transverse aponeurosis. Reduces the fatty tissue in abdominal cavity, we sutured the hernia ring by absorbable suture anchored with no absorbable clip. The fatty tissue extraperitoneally repositioned allowed the closure of the peritoneum with absorbable suture anchored with no absorbable clip. Drain has been placed in abdominal cavity. This is the intraperitoneal surgical outcome. We decided to use a primary defect closure because the defect had a diameter inferior to the trocar access and because only aponeurosis of the transverse abdominal muscle was injured. All other muscular structures of the abdominal wall were intact. Several different surgical strategies have been adopted for spigelian hernia repair. Open approach with or not mesh placement, laparoscopic approach like simple primary defect closure, intraperitoneal online method, transabdominal preperitoneal mesh placement, totally extraperitoneal mesh placement. Our technique allowed a minimal postoperatory risk with the early disappearance of pain and early and safe discharge. Several recent technical innovations have allowed us to repair the spigelian hernia. As shown in this care report, our technique was performed successfully, highlighting its safety and feasibility. Thank you, everybody, for attention.
Good afternoon, everyone. My name is Najlaa Aljefree. I am an assistant professor in nutrition in King Abdulaziz University, Jeddah, Saudi Arabia. Today, I will present my research titled Impact of the Intake of Snacks and Lifestyle Behaviors on Obesity Among University Students Living in Jeddah, Saudi Arabia. Okay, today I will present a brief background, why conduct the study and what is the aim of this research. And after that, I will talk about the research methods, the most important results, and finally, conclusion. Has greatly increased over the last decades. The prevalence rates of overweight and obese adults are estimated to be approximately between 25 to 50%, respectively, in the Arabian Gulf states, including Saudi Arabia. So we have a very high rates of obesity. Obesity is linked to several controllable variables, including physical inactivity, sedentary lifestyle, and poor dietary habits. Snacking is a term used to describe the intake of food and beverages such as chips, chocolates, and soft drinks. Snacking is frequently linked to negative health outcomes and poor dietary habits, and has thus been considered contributing factors in overweight or obese individuals. University is a critical age of young adults. University is a critical age for young adults in terms of dietary choices and weight gain. So why we conduct the study? The previous studies that have assessed the association between snacking and obesity have generated contradictory results. Snacking may not always promote an individual to obesity, as a higher eating frequency may be beneficial in terms of body weight regulation and energy balance. Snacking could decrease calorie intake when replacing main meals. Regardless of the possible link between snack intake and obesity, the frequency of snacking among young adults has not been thoroughly examined in Saudi Arabia. Therefore, this study aimed to investigate the association between obesity and the intake of snacks and lifestyle behaviors among university students in Saudi Arabia. From both genders made up the study samples, and the total population of students in KU in 2019 was approximately 18,000 students. Giving this number and using the sample size calculator, the sample size needed to achieve sufficient statistical power was 659 students. This is a cross-sectional study which was approved by the Biomedical Ethics Research Committee at KU. The invitation to participate in the survey was forwarded to students via university email, the official email. The email and the introduction to the online questionnaire explained the aim of the study and provided guarantees of anonymity throughout the investigation. The questionnaire was written in Arabic. The questions included in the survey were developed using data from previous studies. Questionnaire design. An online survey collected data on socio-demographic characteristics, including age, gender, social status, nationality, monthly household income. Also, data regarding height and weight to calculate BMI was provided. information regarding lifestyle behaviors, including physical activity, time spent watching TV or using mobile phone per day, watch food advertisement and sleeping hours. Also, information regarding dietary habits, number of main meals consumed per day, breakfast consumption, and data regarding snack intake, including the frequency of snack intake per week, time of snacks, activities while eating snacks, and the type of snacks as well. The most important results revealed from this research was as follows. The data were obtained from 662 university students, as we said previously. The majority of study participants were female, were singles, were Saudis, and were aged between 18 to 21 years old, so they're fairly young. There were insignificant association. The results revealed insignificant association between socio-demographic characteristic and obesity. The prevalence of normal weight, overweight, and obesity was reported as 48%, 18%, and almost 13%, respectively, among study participants. Is my voice... Can you hear my voice?
Yes.
Okay. This table presents results regarding the lifestyle behaviors of a study population according to BMI. As we can see from this table, there was no significant differences between obese students and non-obese students regarding in terms of lifestyle behaviors, including physical activity, watching TV or using mobile phone, watching food advertisements, sleeping hours, time of sleep, and sleeping disorders. The second table present information regarding meals and breakfast pattern of the study population according to BMI. As we can see from this table, both groups, non-obese and obese students, had 2 to 3 meals per day, and there was a significant differences between the both group in number of meals. As we can see, obese students consume 2 meals greater than non-obese students. Also, type of breakfast consumed, there was the results revealed that there was a significant differences, as obese students were significantly consumed higher amount of cereals in breakfast than non-obese students, while non-obese students had higher intake of beverages than obese students, had significantly higher intake of beverages than obese students. There was no significant differences between both groups in eating breakfast and eating breakfast at university. Okay, the third table represents the intake of snacks of the study population according to BMI. As we can see, both groups, non-obese and obese students, consumed, like 1/3 of them consumed breakfast or consumed breakfast in a daily basis, and almost 1/4 consumed breakfast 1 to 2 times per week and 3 to 4 times per week. However, there was no significant differences between obese and non-obese students in frequency of eating breakfast and in the time of snacking and activity during snacking. On the other hand, there was a significant differences between obese and non-obese students in terms of type of snacks. We can see from this table that obese students consumed were significantly consumed higher amount of potato chips and popcorns and biscuits than non-obese students, while non-obese students, had consumed higher amount of salads than obese students. So the results actually made sense. In conclusion, the current study investigated lifestyle behaviors and type of snacks related to risk of obesity among university students. Snacks consumed contribute to the intake of daily energy and nutrients and thus affect the overall quality of the diet. The most highly consumed snacks among our study participants were considered unhealthy items except for fruits, vegetables, and nuts. Consumption of potato chips, popcorn, and biscuits as snacks items were highly associated with obesity risk, whereas salads intake was associated with a decreased obesity risk. The university environment was associated with reduced consumption of healthy types of snacks, such as fruits, vegetables, nuts, and dairy products. Health education plans and programs among university students are crucial to encourage healthy eating habits, including eating breakfast and frequent consumption of healthy snacks. Universities should also focus on the food environment of campuses and ensure access to healthy snacks at reasonable prices, which is essential in developing healthy dietary behaviors, decreasing the high rates of obesity in young adults, and ultimately improving public health. And this is the references. Thank you so much for listening. And if there's any questions, I'm here. Thank you.
This is a clinical case that I present, and the title is Amiodarone-induced lung toxicity, a case not correctly framed initially. I work as head of thoracic endoscopy service at Villa Aurora Hospital in Reggio Calabria, and I have an outpatient clinic where patients come for visit. And as you can see, there is a X-ray chest radiograph that how you can see shows a pattern of a reticular pattern bilateral that is one of presentation of interstitial lung disease. The interstitial lung disease it's a disease that have some diseases that includes a set of pathologies that must be excluded when the patient comes to us. In fact, in diagnostic workup of IPF, idiopathic pulmonary fibrosis, it is important to have a good history and clinical examination for excluded specific diagnosis. One of the most important specific diagnosis is drug-induced pulmonary fibrosis. It's important the workup, the diagnostic workup, because a true and comprehensive history may provide invaluable information that can suggest certain entities and provide suspicion that a patient may have specific diagnoses, like, say, Athol Wells and Kissy Meyer in translation respiratory medicine. The clinical case presentation is a presentation of 6-year-old Caucasian female, former smoker of 10-pack year, presented to the emergency department of Polistena Hospital for dyspnea and evening febrile episodes in December 2022. The patient had a clinical history of no exposure to chemicals, vaping, pets, including birds, hot tubes or humidifiers, esophageal hiatal hernia, previous surgery for cerebral aneurysm, past SARS-CoV-2 infection in July 2022, and arrhythmic heart disease, for which she had been taking on indication of cardiology specialist amiodarone at dosage of 200 milligrams per day for the last 2 years. The patient declares on hospital admission that have normal vital parameters. On thoracic examination, have reduced vesicular murmur with bilateral velcro-like records and bilateral hypotransmitted tactile fremitus and clear pulmonary sound. On admission at the emergency department was not performed bronchoscopy because the hospital did not have the possibility to carry out the endoscopy procedure due to a lack of instrumentation. And when the patient came to my open clinic, she showed me her documentation, and I carry out a spirometry with the machine that you can see, called Pulmon Mini Box Plus, that documented moderated restrictive pattern, how you can see in this table. In this table, you can see the laboratory exams and the spirometry results. We can see that there is an increase of white blood cells with increasing increased levels of LDH and high eosinophilic cell count at leukocyte count. In spirometry, you can see that there is a reduction of total lung capacity with restrictive pattern and reducing in peak flow. After I treat the patient with antibiotics, OCS, and ICS LABA for 3 months, she repeat laboratory exams and spirometry, and as you can see, there is a reduction, strongly reduction in white blood cells with reduction of LDH and markedly reduction in eosinophil count with reduction of PCR and increasing in TLC in percentage and PEF. The CT scan show there is in this slide CT scan at time 0 and at 3 months after therapy. In the time 0, you can see that there is areas of bilateral apical and centrilobular consolidation with thickening of pulmonary reticular interstitium of intra and interlobular septa, with predominance in the right apical zones, with the presence in both lungs at submandibular zones of solid centrilobular consolidation. On the right, you can see the CT scan at 3 months that show that the patient, after oral corticosteroid, inhaled corticosteroid, and long-acting bronchodilator, there is a improve in apical, middle, and basal areas, and almost a complete regression of areas of consolidation. The case was concluded with the following diagnosis: APT, amiodarone-induced pulmonary toxicity. That is a disease that represents the 45% of patients with suspicious of IPF. Pulmonary function tests highlight a moderately restrictive pattern on spirometry with lowered forced vital capacity and a small reduction in diffusing lung capacity of carbon monoxide, DLCO. There is an important variation of peak flow in 2 spirometry on therapy prescribed that indicates suspicious of asthmatic pattern in ex-smoker. Blood tests can suggest the presence of non-specific inflammatory syndrome and showing leukocytosis and higher values of erythrocyte sedimentation rate and C-reactive protein. However, there are no specific markers that identify pulmonary inflammation. The role of LDH in monitoring the pathology is for me a new perspective, and it is necessary to add in common routine laboratory tests. The scarcity of human and instrumental resources in public hospitals in Italy, it's increasingly directs patients to turn to private specialists and allows them to see cases that are normally dealt with in a hospital setting. I conclude with the last take-home message that says that the territorial specialist is therefore required to find out about the systemic side effect of drugs, of individual drugs, which make it possible to manage the patient without subjecting patient to potentially invasive procedure. Because in this case report, the patient don't perform bronchoscopy. That is an invasive procedure. And I conclude. Thank you for the attention.
Thank you for the opportunity to present the case challenging diagnosis of amebiasis in non-endemic region. And as you know, amebiasis is an infection caused with protozoan parasite Entamoeba histolytica. And the genus consists of at least 8 species that are able to inhabit in human intestine. And Entamoeba histolytica is the only pathogenic species of Entamoeba is transmitted through the ingestion of cysts found in fecal contaminated food or water sources. The life cycle is relatively simple and consists of 2 stages, infective cyst stage and invasive trophozoite stage. And the humans are a primary known reservoir for Entamoeba. The main source of transmission is chronically infected human. So the stool infected with the cyst form of parasite may contaminate fresh food and water sources. And other common source of transmission is sexual contact. Ingested infective cysts travel through the good lumen to the small intestine. Here, cysts undergo excision and invasive forms of Entamoeba may invade intestinal epithelial cells and cause the inflammation. In addition, they can travel through the blood and invade in liver, lungs, brain. Sometimes there are cardiac sites. And new generated cysts are excreted in stool. So according to the World Health Organization, approximately 500 million people could be infected with Entamoeba. Only 10% of these individuals likely have species of Entamoeba histolytica, and the other rest non-pathogenic species. Amebiasis can cause up to 1,000 deaths annually. It's third leading cause of death due to protozoan infection. And in addition, it is the third most frequently isolated pathogen among the returning travelers. Here is a demonstrated schematic presentation of endemic foci of intestinal and extraintestinal amebiasis in each ecozone. As for incidence of protozoan infection in the Russian Federation, according to the Federal Service for Supervision of Consumer Rights Protection and Human Well-being from 2018, the incidence of amebiasis per 100,000 population exceeds the national average in 16 subjects. Mostly prevalence of amebiasis is in south regions, as it's shown here on the map. Up to 19% of amebic infections are asymptomatic. Approximately 10% of those infected progressing to have symptoms. Amebic colitis is the most common symptomatic manifestation, with diarrhea, with blood and mucus, high fever, abdominal pain, sometimes formation of tumor-like granulation mass referred to as ameboma. And if trophozoites disseminate, they can cause extraintestinal sites. So laboratory tests are diagnostic of intestinal amebiasis is challenging because it relies on clinical symptoms and laboratory tests that lack high sensitivity and specificity. Diagnostic methods are based on parasitological, immunological, and molecular techniques. The laboratory diagnostic of intestinal disease can be made by microscopy, biochemical methods such as culture and isoenzyme analysis, antigen detection tests, molecular-based tests, and point-of-care tests. Microscopy is still frequently practiced in many laboratories, particularly in developing countries. The direct examination of fresh samples, it's not a sensitive method. Disadvantages of the method are lack of trained microscopists. To identify motylite trophozoid stool samples need to be examined within 1 hour of collection, or should be used good fixatives, and the higher possibility to find is higher in loose stool. And sometimes it's very difficult to differentiate among the protozoan, among the species of entamoeba. So in Russian Federation, we are still using microscopic examination. We have PCR test and antibody detection of in blood. The laboratory diagnostic of extraintestinal amebiasis is a little bit different. Patients with extraintestinal amebiasis may not have a concurrent amebic colitis, so analysis of stool feces are generally not performed. Instrumental diagnostic includes ultrasound, CT scan, MRI, and colonoscopy. Ultrasound and CT scan in amebic colitis can demonstrate the typical involvement of cecum and rectum that are a high sensitive method, but not specific. Ultrasonography is preferred because of low cost, rapidity, and lack of adverse events. But CT scan may be slightly more sensitive than ultrasonography. For example, in cerebral amebiasis, it could show the irregular lesions without surrounding capsule or enhancement. Colonoscopy may show the ulcers, aphthous in cecum and ascending colon, and in rectum. Biopsies can be done, but the negative biopsies doesn't rule out amebiasis, and the images of the colon could be similar with other diseases. What will I show later on the later slides? So the treatment of amebiasis consists in application of 2 groups of amebicides, tissue amebicides and luminal amebicides. First are absorbed in blood and act in tissue, and the primary therapy of choice is metronidazole. It's still effective and commercially available at low cost. And the luminal amebicides act only in intestinal lumen and are used to eliminate the cysts. So about our case report, it's a young female, 38-year-old living in Moscow. From her anamnesis in 2019, she entered emergency with epigastric pain radiating to the right hypogastrium, and at the same time her blood tests were normal, and ultrasound showed the thickening wall of cecum and appendix and infiltration near appendix. She was transferred to the surgical department under supervision with her symptomatic therapy. After a week of symptomatic therapy, ultrasound showed the regression of infiltrate near cecum and appendix, and it was decided to do a colonoscopy. Her colonoscopy in May 2019 findings included cecum infiltration, ulcers in ascending and transverse colon, and aphthous changes in sigmoid colon. Biopsy was not so specific, pieces of colon mucosa with edema, scattered lymphatic infiltration, and formation of granuloma in one area. Small bowel follow-up through barium examination didn't reveal any changes. So she was diagnosed with inflammatory bowel disease, undifferentiated colitis, more suspicion to Crohn's disease. And she was prescribed the treatment with mesalazine, 4 grams per 8 weeks, and after control colonoscopy, which showed the mild inflammation in cecum and sigmoid colon, it was decided to continue with mesalazine. So in April 2021, with complaints on abdominal bloating and bowel growling, she entered our gastroenterology department, and due to her previous diagnosis and treatment with mesalazine, we did some examinations. Her blood tests were normal, CRP was normal too, fecal calprotectin was 3 norms higher. And due to her diagnosis of Crohn's colitis or undifferentiated colitis, we did a colonoscopy, and the findings included multiply irregular-shaped ulcers with the surrounding erythema, and they were covered with yellowish exudate. The changes were in cecum and ascending colon, and mucosa between the ulcers was normal. So the amebiasis could mimic colonic shigellosis, tuberculosis, and inflammatory bowel disease, sometimes cancer. And these are the images of confirmed shigellosis of Bauginum flap. It showed the same irregular ulcers covered by exudate and some redness, punctate spots. These are the images of confirmed tuberculosis. The ulcers are often surrounded by perifocal inflammatory shaft, and the ulcers often merge with each other, occupying the significant length of intestine. They can scare, forming annular narrowing of the intestine. And suggested changes for Crohn's colitis are deep ulcers, large deep ulcers, and cobblestone appearance, mucosal nodularity, again edema and stenosis, and it mainly show segmental involvement and could be perianal diseases. The consequences of not recognizing amoebic colitis can be catastrophic. It may result in administration of steroids or in major cases of intestinal resection for suspected inflammatory bowel disease. And according to the review of cases of corticosteroid therapy for initially misdiagnosed colitis, including IBD, intestinal vasculitis, and tuberculosis, 24 cases of patients developed severe and fulminant amoebic colitis. And the main role is a well-collected anamnesis, including the travel to endemic regions. In our case, it was Asia in 2019, she was in Indonesia, and 2020, Sri Lanka. After colonoscopy, we did additional diagnostic to exclude the bacterial infections too, and stool feces microscopy with formalin easy concentration revealed was positive for Entamoeba histolytica. At the same time, we received the serology. It was positive with antibodies. Serology assay for other bacteriological diseases such as salmonellose, shigellosis, and yersiniosis were negative. Clostridium difficile test of toxin test in feces was negative. We did abdominal ultrasound. It doesn't reveal any sites in organs in liver, and small bowel follow through barium examination was without changes too. At the same time, we received the histology. It was with purulent necrotic detritus with presence of microphage-like structures and oval ovoid shape with granular eosinophilic cytoplasm and with presence of rounded nuclei. And it was a pus-positive cytoplasm reaction. So she was diagnosed with intestinal amebiasis, and we stopped mesalazine and started metronidazole. And her control feces assay in 3 months was normal without any intimabe histolytica. And we recommend her to control colonoscopy to rule out inflammatory bowel disease, because it can be the same time inflammatory bowel disease and amebiasis. And as you see on the image, in the images, the ulcers are cured and the mucosa of colon is normal. So, however, in 2022, after 7 months of her disease and treatment, she relapses with positive tests on real-time PCR and microscopy. And her colon ultrasound again showed the thickening wall of cecum, initial part of ascending colon, and ileocecal region was not narrowed. And we used the second line of treatment with tinidazole, and due to chronic course of disease, it was suggested to find paromomycin, which is not available in Russian Federation. It's not registered, and only after this drug we achieved the long-term remission. And this year in February, because of fear of relapse, the patient did a colonoscopy, and it was without any pathological changes. So, to conclusion, amebiasis is not a diagnosis of endemic regions. Amebicolitis should be included in differential diagnosis of all patients with suspected inflammatory bowel disease and before prescribing steroids. And our case shows long-term misdiagnosis of amebiasis due to lack of awareness and alertness of physicians. The absence of pathognomonic symptoms is clinical in this clinical case. Made it difficult to timely diagnose and treat the chronic protozoan infection. And also the unavailability of lumen amebicides delayed the treatment, and she relapsed. And the correct diagnosis of intestinal amebiasis is critical for controlling the spread of infection and avoiding unnecessary treatments. And I want to conclude with a quote of Johann Goethe: "We see only what we know." For a long period of time here in Russia, we have been teaching doctors to be very in terms of diagnosing inflammatory bowel disease. But now we need to learn that not every erosive and ulcerative changes in intestine means inflammatory bowel disease. And special thanks for my colleagues for helping me with this presentation and with their endoscopic pictures from self-archives with tuberculosis. Thank you very much for your attention.
I'm basically a family physician. I graduated Tel Aviv University, and then many years later, I was asked to lead the cannabis unit in the Israeli cannabis medical unit in the Ministry of Health. I did it for 6 years. A very interesting times and not very simple. Okay. Before starting, I want to make a tribute to Professor Rafael Meshulam, who died a few months ago. Professor Meshulam was the one who began the research and development of the cannabis field. He was the first one to describe the THC. It's all over the world, and I was lucky enough to be a student. The subject I want to say a few words about is cannabis is so famous all over the world. Millions of people use it. For thousands of years, we believe that more than 6,000 years it was used. And when we try to check it together, according to the medical quality control standards, we have a lot of very poorly designed research projects and very little good quality research. And it's very frustrating because as a physician, we want to use it, and we want to use it according to the medical standards, GMP and everything, but it is not progressing as it should. So what I was trying to evaluate the obstacles, why the cannabis research is so problematic, what's holding it up. And the first and the most important thing is the basic, the legislation, the regulations that prevent research. I don't intend to go into depth to the reason of such legislation. Of course, usually, as everything, it has a reason based on money competition, other products that perceived the cannabis as something which is very competitive to their products. Anyway, especially in the States, they made some terrible legislation and forbid usage of cannabis. Even it was 100 years ago, it was largely used for many indications. Some of them we do believe today they are still should be used, but it was forbidden. And what is worse, the legislation forbid also cannabis research, and this is something that prevented quality control and the research to larger use of cannabis. Of course, along with the medical approach, there is also a part which is a lot larger, is the usage of cannabis for social purposes. The moment those two fields contradicted, many people perceived that the medical usage of cannabis is kind of point of entry for usage for social purposes. And it stopped the many good physicians who just didn't want to be mixed with something which is illegal and leading to problems like habit formation. During the last years, I would say the last 15 years, many countries stopped this approach and started the process of legislation that today most of the countries, most of the states in the United States already allow cannabis for medical purposes. Many allow also for social purposes. Today we are quite sure that all those intimidations about the side effects of cannabis are not based. Okay. So after mentioning the legislation problems, we have one terrible problem, which is prejudice. Prejudice of people who are afraid of cannabis, being sure it's kind of that it should be put with cocaine and heroin, like being something so dangerous as the others, which is not. And we have enough research today to be sure that it is not as dangerous as the other substances. And I don't try to say that it has no problems. We have problems even of habit formation, addiction, but those numbers are very, very little. I will believe that about 13% of the users will create some kind of addiction, but usually it could be taken without such problem. So prejudice is on the physician's level, which usually is connected with lack of knowledge. Prejudice is connected with the patients on the patient's level. And there is one interesting point here. I don't mention here the media. The media is not prejudiced. Well, it is prejudiced, but in the opposite direction. Many large parts of the media are sure that cannabis is kind of panacea, kind of medication that will cure everything, and they promote the use of cannabis to a level which has nothing to do with reality. They create expectations of the patients that it will cure everything. Many patients are sure the cannabis will cure cancer, which we doubt. Of course, there are some new research studies about influence of cannabis on certain types of cancer, where they are very interesting, maybe even promising, but far away from describing cannabis as a cure to cancer. Now, as a result of this unsafe ground we step on, no legislation in many places, the physicians are responsible. If a physician will give cannabis to somebody, he will be liable to malpractice suits. And this is something that every physician is afraid of. As long as it is not recognized as medication, as it is not produced under strict GMP standards, we, as very, very careful physicians, are not sure what to do about it. In my country, the solution was a paper that was prepared by professionals with the leading by the Ministry of Health, and I'm proud to say that I was part of this process. And this paper became to have some kind of a backup for physicians. If you don't have a good research studies and you want to use the cannabis, you can say, okay, I did what the Minister of Health allowed. And then you have kind of defense. The second problem about research is that the cannabis is a very complex plant. It is composed of about 600 different cannabinoids, 60 flavonoids, and 60 terpenes. And I'm sure those numbers are not accurate numbers. Everybody will give you others, but this is more or less the number of substances in each plant. Now, if you grow the cannabis with lights or heat, you will get different results than if you do it under other conditions. So the moment you have this plant to become kind of medication, you want it to be consistent, produced under the same circumstances, with the same quality control, with the same results. And those we are only at the beginning of creating such process. So the production is problematic, and if you don't have consistent material, consistent medication, you cannot do research. You cannot do research giving the patient one day this cannabis and another day another. Ways of administrations, it is also problematic because most of our patients prefer the respiratory system approach. And that means smoking. And as a physician, we hate smoking. We don't know what is the amount absorbed. And So we do everything we can to promote research of, if you want to take it through lungs, because the influence is quicker, then maybe use inhalers like salbutamol or steroids. This is a lot better, but it's on the stage of development. The digestive system with oil, the cannabis is soluble in oil, skin patches, even the rectal root. Now the new development, which I believe will be really important, is usage of nanotechnology as a system to introduce the cannabis. Those guys that use the nanotechnology, and I'm proud to say that some of them are also in Israel, they can insert the cannabis in a very small package, nanotechnology, and they can direct it to places which we were not able to approach first. For example, to cross the blood-brain barrier and to use it for intracranial usage, intracerebral, or in other places. This is a really interesting and promising field. The moment we don't have reliable information research, then our colleagues from the media celebrate with defamation that cannabis is doing all the problems in the world, then using, or others think about it as a panacea that will cure everything. And since there are no reliable sources, we have very unreliable media and results. Just one very small thing, but I believe it's important. As you noticed, I use only the word cannabis. I don't use the name marijuana, because this is kind of a racial term that was invented in the States in the 20s of the last century. What is marijuana? Marijuana is Maria, when she used cannabis and she became a whore. Or Juan, the male partner that used marijuana and starts killing or raping white women. So it's kind of a very insulting term. I prefer not to use it. We use the name of cannabis. Now, this is multi-million-dollar industry. Medications are only small part of it because of the problems I mentioned about the production, but there are three fields with billions of dollars options. One is to use the cannabis for cosmetics. Cosmetics is usually based on CBD, which is a non-psychological influencing substance. I remember when I was walking in a market in Montevideo, and there were a lot of people selling cosmetic with CBD with a promise: you put it on your face, to the lady, and you will become young and beautiful forever. And believe me, many, many very nice women, including my wife, bought it immediately. Food supplements. In many places all over the world, you can see food supplements, including CBD, where I believe that we should go on with the direction that we should exclude the CBD out of the narcotic convention. This could be sold in the open places, in supermarkets, I don't care, because it has no problems. The products that include THC, that is different issue. Veterinary products, most of the medication we use for human could be used for veterinary problems. I saw once ape, I mean a monkey in a zoo, that it has a terrible arthritis, and in order to help him, I was asked to give him cannabis, and it really couldn't be done. So, what is the summary? What is the conclusions of my short lecture? I believe that we shall start with asking our legislations to do the best as we can to change the legislation. The first step should be taking the CBD out of the Narcotic Convention. The second is the education of physicians and patients and promoting the production of all the future medication under strict GMP rules. Thank you. I hope the problem was presented, and thank you for the opportunity to do it.
Thank you.
Problem of reducing mortality from pneumonia and other complications caused by COVID-19. This alternative treatment is the use of system method of reaching, SML. The proposed solution is based on almost 30 years of experiments in the use of SML in elderly people with multi-organ pathology and children treated at the Academy of Urotherapy of St. Petersburg. Our experiments in the treatment of post-COVID syndrome 2020-2023 shows that it is possible, moreover, with high efficiency. Based on the analysis of the mechanism of pathogenesis of the COVID-19 virus, our article was published priority of April 21, 2021 in relation to the treatment of post-COVID syndrome. This work was published in Acta Scientific Medical Sciences. Even earlier, an article was published in Reducing Mortality from Complication of Post-COVID Syndrome, as well as in complications arising from vaccination against coronavirus, regardless to the type of vaccines used. The second publication in Acta Scientific Medical Science. Post-COVID-19, post-COVID syndrome. The author of this message owns a series of publications in the period 2020 to 2023, highlighting the features of pathogenesis of a new disease, COVID-19 post-COVID syndrome, as well as a method of treatment and prevention of the disease based on the scientifically proven medicinal properties of the medical leech, Hirudo medicinalis. The editors of 6 scientific medical journals adopted the author's concept of the name of the disease, COVID-19 post-COVID syndrome. This definition of a new pandemic is important not only from a taxonomic point of view, but above all from a mental point of view, since it gives the doctor the understanding of the complexity of the disease and requires monitoring patients throughout this period. For example, monitoring the dynamics of D-dimers, prothrombin time, platelet count, and the level of fibrinogen in the blood of convalescent. Now, these are the most informative markers of the danger of thrombosis. Next slide. The term long COVID doesn't reflect the substance of the disease process. In addition, in this series of publications, we analyze the most recent and proven various aspects of the pathogenesis of COVID-19 post-COVID syndrome. As a result of this campaign, our recommendations are the follows. In the acute period of this disease, we conduct leaching courses daily, and in the second phase of the disease, 2 sessions per week for 18 to 24 months. This technology is a serious alternative to oral anticoagulants and plasmapheresis. The use of direct anticoagulants has a number of significant contraindications and complications in the defeat of the central nervous system, can cause bleeding, nasal, throat, and renal. Plasmapheresis is available only to well-equipped clinics. As the author of mentioned publication, I want to note a whole series of works published in 2020 to 21-23 in the different journals. In these works, a number of new fundamental data have been published that make it possible to evaluate heredotherapy as a pathogenetic method of treating complications of COVID-19 post-COVID syndrome and vaccinations against coronavirus regardless of its strain characteristics. These are the discoveries of a new effects of heredotherapy. Energy, near-read stimulating, wave acoustic, detoxification, negentropic, aquastructuring, antiviral, resonance wave, and others. In addition, the SML allows you to strengthen the therapeutic effect from synthetic drugs recommended by the national health centers of the world in the treatment of COVID-19 post-COVID syndrome. The proposed treatment technology has proven its effectiveness and the possibility to prevent complications from this disease in Russia, saved many lives. The following research methods were used. In this study, the medical leech is used not only as a therapeutic agent, but also as a research tool aquasystem of men. The next slide, on the next slide, you can see the different discoveries about the new facts of heredotherapy or leaching. The next slide. The influence of heredotherapy on the results of GDV, the Kirlianography. The left picture before and right picture after the application of leeches. Next slide. Water and microwave discharge. The simple dissociation of aquasystem gives us the energy 55.4 kilojoule per mole. And stimulating dissociation of aquasystem gives us the energy in 10 times higher, 532.8 kilojoule per mole. Next slide. We can see now the organotypic culture of the chicken embryo spinal ganglia. Stimulation of nerve cells, neurons, observed by fast contrast microscopy in the culture of nerve ganglion cells of 10-day chicken embryo. The left picture. Initial state B, after exposure to leeches, visible characteristic growth of neuritis processes from our published work. Next slide. Changes in electromagnetic activity of the child's brain after a session of heredotherapy. On this picture, we can see the activation of the most neurotransmitters of the brain of child with diagnosis of alalia. It was the picture of post factum. And now I can show you dynamics, the next slide, of response activation of neurotransmitter system of the brain during a session of chirurgotherapy. And we can see the changes of the fields of neurotransmitters in the brain. The dynamics of response activation of neurotransmitter system of the brain in a session of chirurgotherapy, brain of a 4-year-old child with diagnosis alalia. Next slide, investigation of acoustic effect of medical leeches. The high picture sensor, the center, the beginning, and the low picture, the finish of leech application. Next slide. The high picture. The original record signal of leeches in the process of blood sucking. And we can see the song leeches and its spectrum. Recording an acoustic signal of leeches in the process of blood sucking after Fourier transform. This is a real symphony of leeches. Next slide. The demonstration of toxicity of the blood of patients with COVID-19, post-COVID syndrome. Here you can see the dynamics of death of leech treatment in a patient with chronic drug poisoning diagnosis, Koževnikov's epilepsy, the small form of epilepsy. The period of pharmacological treatment is 11 years. And we can see the toxicity of blood, and after treatment of leachment, we can normal blood. Next slide. Patient, young lady, 33 years old, diagnosis. Ovarian cyst, the state after 2 operations for the removal of ovaries. Bad habits, smoking experience 20 years. The follow-up period is 25 months. And you can see also the toxicity of blood, and after leech treatment, we can see the normal blood. The third history, patient 68 years old, diagnosis, hypertension of heart, DSP lumbar, intervertebral hernias, common osteochondrosis, prostate adenoma, chronic prostatitis, systemic connective tissue disease. From anamnesis, 25 years ago, he worked with mercury and salts, often heavy metals in a research laboratory. And you can see that during 2 years, his blood demonstrated the high level of toxicity. And the next slide, this is a spotty-mole of destabilize 2. Destabilize 2 is the enzyme that can destroy the thrombosis in the vessels. Spatial model of destabilize 2 structure in combination with NAC3 and acetylglucosamine. Most important hydrogen connections between side chains are shown by dotted lines. Zavalova et al. Summary. During the pandemic COVID-19 post-COVID syndrome, we have demonstrated that chirurgotherapy may be as an effective and dominant monotherapy. Thank you very much for your attention.
Well, we're going through a very, very difficult and complex time, so I'm happy to join you today. My keynote focuses on health policy during COVID based on 12 studies that I performed throughout the 5 waves of COVID. And I hope that although we're from different disciplines, you'll still be able to get some insights regarding your field. Okay, so many health systems in the world are national health systems, and that means that they are progressive, that citizens pay. In Israel, we each pay 8.3% of the income, and that aims to provide everyone, regardless of the socioeconomic status, race, gender, beliefs, etc., an equal level of scope and quality of health services. The Bloomberg organization ranked Israel consecutively as 6th in efficiency out of 51 health systems. And the question is, does this ranking affect patient-centered care or the quality of care? And we will see, based on the studies, that it is not necessarily so. So many national health systems aspire at minimizing disparities. As far as religious minorities in Israel, 37.5% of the population comprises religious minorities. These are Jewish Orthodox, Muslims, Christians, Bedouins, Druze, Baha'is. They are characterized as close-knit communities with very large families where the collective values transcribe the personal ones. These groups have specific death rituals and values and beliefs that transcend those of individuals. And they all have complicated relationships with the government, and they are mostly guided by their spiritual leadership. Throughout the COVID pandemic, although physical distancing was vital to contain the virus, the compliance across the different religious minorities was very poor compared to the compliance of the majority of the population. For example, the Jewish ultra-Orthodox comprised 12.6% of the population, but because the compliance with the guidelines was so low, 40% of hospitalized patients due to COVID were from the Jewish ultra-Orthodox minority. The same could be said regarding the Arab Muslims. They comprise 21% of the population, but 33% of hospitalized COVID patients were Muslims. There was a failure to contain the virus, resulting in a very high morbidity and spread across groups of the population, and the government was unsuccessful in reducing this morbidity. And then the pinnacle of science happened, and the vaccines arrived, and everyone in the world could read that in 2 months, 70% of the Israeli population was vaccinated, making Israel first among the OECD countries. These vaccinations were widely available, but 12%, and these are minority populations, rejected the vaccine. Now, we know that public health depends on coverage among all groups of the population. So within 3 months, Israel dropped in its international ranking. There was an acute rise in infection rates, which required a booster vaccine. The health authorities issued a vaccine passport to restrict the movement of non-vaccinated people, but lo and behold, 48% of the population rejected the booster vaccine, which reflects a high level of distrust in the health authorities, distrust in health policymakers. The media, however, kept sending messages that increased the polarization and the discrimination against minorities who were perceived as those that do not comply with guidelines and risk the rest of the population. The goals of my studies were to complement epidemiological studies by voicing these minorities and respond to previous calls to experience what religious minorities, to examine their experiences during the COVID-19 period. The importance was that these studies can direct changes in health policies, not only in emergencies, but also in regular times, and focus on the issue of inclusiveness of public health services. So the research questions focused on lived experiences and perceptions among members of health minorities. I wanted to understand what underlies the harnessing of guidelines, what are the main causes of cultural clashes, and what can we learn from these experiences of the COVID-19 going forward. There were many challenges performing these 12 studies, challenges that were related to the fact that I was perceived as a potential COVID-19 vehicle, that the guidelines inhibited traditional data collection. I wanted to bring timely, actionable insights. And there were also operations-related challenges, like having to use the Zoom platform with minority populations that aren't necessarily using Wi-Fi and internet platform. And I needed to examine my own values and make sure that I'm not patronizing when I interview these populations that chose to conduct themselves differently from the guidelines, and also being a secular woman made it challenging to approach these communities. But I overcame these challenges. I worked with moderators from these communities. I had the endorsement of their spiritual leaders who, for the sake of learning and enhancing the knowledge, encouraged members of their communities to cooperate and participate in the studies. So let's see the findings, and I'll present them by the major minorities, the Jewish Orthodox minority and the Muslim minority, and what did they experience? The Jewish Orthodox leaders decided that since hospitalization of members was isolating them from the community in overflowing hospitals, they developed distrust in health authorities and refused to hospitalize members of the community. 6 Jewish Orthodox neighborhoods became home to underground home hospitals, secret unsupervised hospitals that provided underground home hospitals, which was a great example of patient-centered care during a crisis, during a pandemic. Everything was done so that the community will be able to preserve its values and not die in solitude in overflowing hospitals, but be surrounded by their families and go about their home activities as much as possible. They purchased equipment and had many physicians volunteer to come and monitor the patients 2-3 times a day. As for the Muslim community, the lack of rituals inhibited respectful meeting and respectful realization of their values, as they believe that the deceased will meet God, but in the lack of those rituals, that wouldn't be possible. The lack of having the spiritual leader, the imam, and the family reciting verses from the Quran was also something that they perceive that jeopardizes their peaceful departure from this world. The burials were very different, guided by the health authorities, without attendance that enables forgiveness, enables sharing, enables final words of prayers. And the imams thought of alternatives that can still accord with the guidelines, but they weren't asked about it. There was one health policy, guidelines that were guidelines for all, and the leadership felt that they are being invalidated, which caused anger and distrust at health authorities. Now, why is this important? Why am I focusing on this? Because distrust was proven to reduce utilization of health services, and what it caused is the deterioration in health conditions of all of these religious minorities, and it deepens the societal polarization because of these clashes, which compounded the poor experience that everyone had during the pandemic. But for religious minorities, it was traumatic. They suffered as they bereaved. They witnessed clashes between the formal guidelines and their beliefs and religious practices. And altogether, it's called secondary traumatic stress, which could have been mitigated had the health authorities considered the beliefs, values, and needs of the different minority groups in the population. Maybe that's not possible in the first and second wave of the pandemic, but as we go forward in the different waves that we had 5 or 6 waves, it would have been possible, and that's what I recommend, to stop and analyze the needs of all the groups of the population if it's a national health system. So what happened in terms of the conduct of the health authorities? There was no acknowledgement of the loss of communities. There was an invalidation of spiritual leaders of those minorities. No awareness of the need to adapt to the different values and beliefs of the different groups. There were no resources allocated to help plan and achieve practical needs after the death of community members, no grief support, and no access to communication platforms to process grief. And as I obtained the insights and recommendations, I created the voice model. The voice model is a model that shows how inclusiveness could be a major component in health policies, even in health emergencies. What does voice stand for? It stands for values and openness. And if we all have the value of inclusiveness in national health systems, it has to be expressed in practical guidelines throughout the emergencies, inquiry of these values, how they come about, how they are reflected and expressed in the health policy, communicate and collaborate, and explore the new ideas that we have and that we implement in our health policies in order to make national health systems much more inclusive. What are the practice implications when I talk about the voice model? So at a leadership level, we're talking about validating the leadership to create trust, approaching the minority leadership and providing them with transparent empirical data so that they can guide their community members. With members of the community, we want to understand the sources of distrust, the sources of objections to guidelines, and use culturally appropriate channels to communicate with community members. We can engage clinicians from those minorities, just as the Orthodox Jewish community did when they established those underground home hospitals in order to facilitate collaborations. And we can target a community-based effort of collaboration together with leaders. We can use measures for preventing infringement of civil rights of minorities. I don't think that any health authority in the world developed measures for testing whether or not our rights are infringed or respected. Another recommendation is to intervene by channels to increase mutual understanding and encourage collaborations for community-based support for all ages and all backgrounds. How do we do that? I actually developed a model of engaging and rewarding inclusiveness by defining the problem, addressing the lack of diverse talents from all minorities. We need to ask who the health authorities comprise, which minorities are part of boards in health authority boards of policymaking. We need to consider bias of ideas generations and develop inclusive solutions. We need to generate evidence to test the policies, the extent to which they are adaptive to different cultures, and to also address communication biases, because the mainstream communication channels don't always address or even used by different minorities. We have a problem of snowy white pigs. Who is engaged in policymaking? Is the communication inclusive? Is the public engaged enough? When we think forward of future policymaking, how many agents do we have from minority groups? Are advisory groups inclusive enough? And if they're not, in order to maintain health conditions and prevent the deterioration of health of members of religious minorities, we need to do these things and measure trust and measure the utilization of services. If we want to reduce discrimination through leadership education, we need the health leadership to be comprised of people from the different minorities in order to influence the behavior of policymakers and reduce inequity and discrimination. We need to critically appraise our practices and experiences and influence the leadership to create connections and rebuild trust of religious minorities. To promote inclusiveness and engagement, which will make our health systems much more resilient, we need to build capacity for inclusive leadership. We need to reward inclusive practices, change perceptions about where the knowledge lies, because the knowledge isn't just with the health authority. There was a lot of knowledge that we could have translated into much better life quality for all of us. We need to be attentive in that way, because people are not just empty vessels. We need to take into account the beliefs of minority groups, not just the majority groups, to value the experiences that religious minorities went throughout the waves of the COVID, and invest in establishing that trust, not only in emergency, but also in routine times. So thanks very much for listening. I hope you could take several points to your health systems to make them more inclusive. And if there are any questions, I'll be happy to answer them.
I would thank the event organizer and, of course, all those who participate in this research. The title is Effect Assessment of Good Practice on Breastfeeding Duration in Pregnant Women at the Hospital of Orvieto District, Umbria Region, Italy, from January 2017 to June 2018. Now we see that breastfeeding is both a right and a public health priority. The aim of this study is to investigate whether care and support practices carried out during the perinatal periods and influence breastfeeding start and duration. The survey represents a progressive input short study that involved 608 women and had given birth from January to December at the Hospital Santa Maria della Stella in Orvieto with follow-ups at 3 and 6 months. The time period, I've seen the time period. Orvieto is a small country hospital and it's a suburban hospital. Data were collected by means of a structured interview by obstetricians, and the participants underwent 2 follow-ups at 3 and at 6 months from the childbirth. 80% of women has Italian citizenship and half resided in Orvieto district. The others come from neighboring zones. Mean age of Italian women in our sample was 32 years and 50 years for the foreign ones. The variable analyzed were those useful for good practice as recommended by the World Health Organization and other international institutions. And they are citizenship, number of childbirths, participation through birth support training courses, childbirth type, resort to all nursery school of rooming, resort to skin, resort to home help. Breastfeeding carry out at discharge at the 3rd month from birth and 6th month from birth. More than half of women interviewed gave birth for the first time. The birth rate in Italy is very low and about 1 and 5 child for women. But we know from the scientific literature that the habits to join meetings that prepare for birth is a very helpful resource for women who improve their awareness and knowledge about good practice during pregnancy, and is useful also for their children. This is true not only for breastfeeding, but even for other healthy lifestyles, for example, alcohol assumption, active and passive smoking, the assumption of folic acid, and the right way to arrange the child in the cradle, etc. Unfortunately, only 44% of women interviewed in our sample joined a training course for supporting childbirth. Okay. It's also very important to take into account the role of predictive factors for a good breastfeeding. In particular, some variable as the childbirth type, cesarean or spontaneous. We have in Italy a high percentage of cesareans birth child, may be inappropriate 30%. rooming, and allows child to stay together, the mother rates in nursing home. 20% of cases, skin-to-skin practice, based on the habitual contact of child with mom's skin, 68% of cases. Then, postpartum home support was asked by 17% of women interviewed. Breastfeeding. Considering the breastfeeding at this age, almost 90% of women performed the exclusive one. Only 1 and 7% was not able to autonomously breastfeed the child. Both for rooming, 94% versus 81%, and childbirth type, more clear for spontaneous childbirth. Now we go to the follow-up, and at third and 6th month, exclusive breastfeeding at the third month from birth still remained high, 67%, and decreased to 53% at the 6th month. Noteworthy, the absence of breastfeeding slightly increased from 13% and at the 3rd month to 20% at the 6th month. But there are significant differences, and so it means good practice. The exclusive breastfeeding for skin to skin is more important, and we can see a significant difference between women that had skin to skin practice, 63 at 3rd month, 63% versus 64%, and at the 6th month, 61% and 48%. There is a significant difference. Another practice that is a good and significant difference is rooming in. In this case, women who practice the rooming in also feed more in an exclusive way with respect to the others. And you can see 94 versus 81, etc. It's important the breastfeeding children type in women who received a cesarean section. The probability to breastfeed in an exclusive way was lower and decreasing from 72 to 58%. And another significant difference is the exclusive breastfeeding at 6th month for critical issue during the hospital permanence. Also, only women out of them experience a critical issue, especially about communication. A significant difference was observed between those who did not meet critical issues and those who did, either at 3rd or 6th month. Another important factor is the citizenship also had an impact. Foreign women are prone to exclusive breastfeeding for longer time. We can see the difference at 6 months, 54 versus 68% for foreign mom. At the end of this study, we have a multivariate statistical analysis with the logistic regression methods, and it detected that the most robust variable in predicting the extension of exclusive breastfeeding until the 6th month was participation to a training courses, citizenship, and skin-to-skin practice. The sample detection of some data about the childbirth and breastfeeding allows to perform epidemiological analysis and obtain significant data for orienting the planning of health and practices in this study. And our study was realized as with descriptive analysis and then with the multivariate analysis. Despite a small sample size, the research highlighted some statistically significant association between good practice and the extension of the exclusive breastfeeding period. In sum, data collection, even in a way that not increases the burden of healthcare professionals, confirms that it's important to assess and ameliorate action and health practice. And at the end, we have seen some limitation, small population size, all with only limited analysis. However, the data obtained were statistically robust. Survey forms should be filled in more carefully, since each missing information or mistake increases the heterogeneity and the error rate. More attention is needed at the follow-up. Science dropout rate was high during the survey. At last, an adjustment of the items in the form to those used and at international level is needed. Thank you for your attention.
Semmelweis University, Budapest, Hungary, and I am working as a cardiology resident in Gozsegin National Cardiovascular Center in Budapest, Hungary. And I would like to introduce my topic, which is the prognostic significance of variant left common pulmonary vein after transcatheter pulmonary vein isolation. So atrial fibrillation is the most common arrhythmia in the clinical practice. Its increasing incidence and prevalence make it a global health problem. And the pathomechanism is based on triggered activity originating mainly from the pulmonary veins and on atrial structural and electrical remodeling, which favors the formation of micro-reentry circuits. Thus, the basis of the treatment of atrial fibrillation is pulmonary vein isolation, which was first described by Heiseger and his colleagues, which you can see on the left side, on the right side of the slide. Shortly, the three pillars of the management of atrial fibrillation, according to the ABC principle, are the anticoagulation and stroke prevention, symptom control, including rhythm control, and of course, catheter ablation, which I would like to highlight as part of my current topic, and the recognition of cardiovascular and other comorbidities is also a key part of the AF treatment. So pulmonary vein isolation, or shortly PVI, in atrial fibrillation now can be used as a first-line treatment. Catheter ablation is included as a class 1 indication in patients with heart failure with a reduced ejection fraction and in patients with a therapeutic refractory paroxysmal or persistent atrial fibrillation. And in addition, in patients not receiving antiarrhythmic therapy, PVI as a treatment option is also available based on patient preference. What is the goal of the ablation procedure itself? So basically, we would like to reach a complete isolation of the pulmonary ossia, and two techniques are currently in use to achieve this and are routinely used in our institution as well. So one of them is a so-called point-by-point radiofrequency ablation with radiofrequency energy, performed with a 3D mapping system, and ablation with cryoenergy, basically freezing the pulmonary ostia with cryoballoons. So in normal left atrial anatomy, 4 pulmonary veins inserted into the left atrium with separate orifices, and the key word here is the separate, because the left common trunk is the most common anatomical variant, but right or bilateral pulmonary trunks and occasional accessory pulmonary veins can also be seen. And these variants are associated with a higher incidence of atrial fibrillation according to literature data. Based on the cardiac CT scan, we define a left common pulmonary venous trunk when the coalescence of the inferior and superior pulmonary vein is at least 5 millimeters before the insertion into the left atrium. When this distance exceeds 15 millimeters, it's considered a long common trunk, and below 15 millimeters, we call it a short common trunk. You can see in the right picture, there's a long common trunk with a 31.4 millimeter trunk distance, and on the left, it's a bit shorter. It's a short common trunk. So experience to date shows that the left common pulmonary venous trunk has not significantly affected the success of pulmonary vein isolation. In addition, it has been described that catheter ablation with cryoballoon is similarly effective to radiofrequency ablation in patients with a left common trunk. However, in our country, we are not aware of any studies to date on this, so our aim was to compare the procedural data and clinical outcomes in patients with left common pulmonary vein versus normal left atrial anatomy for radiofrequency and cryoballoon catheter ablation. In our retrospective study in Godzegan National Cardiovascular Center between October 2019 and March 2022, the presence of a left common pulmonary vein was detected in 42 out of 210 patients with cardiac CT scan undergoing pulmonary vein isolation for atrial fibrillation. In addition, 60 patients with normal left atrial anatomy were included and formed the control group. In the LCPV group, the radiofrequency catheter ablation was performed in more than half of the patients. This ablation technique in the cryoballoon ablation in the control group was used in 35% of the cases. During the 12 months follow-up period, we performed a Holter ECG examination, a transtelephonic ECG examination as part of the outpatient follow-up visits, and reached patients by telephone to assess atrial fibrillation recurrence. This slide shows the statistical methods used in this study. So basically, a total of 34 women and 68 men were included in the study with an average age of 62.6 years. Of those included in the study, 8 patients had a known history of heart failure, and a total of 2 patients had left ventricular ejection fraction of 40% and less based on a transthoracic echocardiography before interventions. And as you can see, no significant difference was found in the main comorbidities between the groups. And there was no significant difference in the use of major antiarrhythmic agents between the studied groups. And the mean left ventricular ejection fraction in the study population was 58.7%. In the LCPV group, short common trunk was detected in 25 cases at all, and long common trunk was detected in 17 cases. The mean distance of the left common trunk in the cryoballoon ablation group was 16.4 millimeters, and it was 13.1 millimeters in the radiofrequency group. And the following results and figures are taken from our article published in early 2023. Firstly, I would like to speak about the complete isolation results. So basically, after radiofrequency catheter ablation, the complete isolation was achieved in 95.7% of the cases. This number was 96.4% of the cases after cryoballoon ablation group. Grouped according to the ablation method, we compared the procedural data for both radiofrequency and cryoballoon ablation in patients with left common pulmonary venous trunk and the control group. For radiofrequency ablation and cryoballoon ablation also, the procedural data such as procedural time, fluoroscopy time, and fluoroscopy dose did not differ significantly between the group with LCPV and the control group, as you can see at the diagrams. Occurrence of atrial fibrillation at the 12 months follow-up with radiofrequency ablation was observed in 7 cases in the group with a common trunk and 5 cases in the control group. After cryoballoon ablation, 6 and 12 cases of arrhythmia recurrence was observed in patients with a common trunk and in the control group, respectively. After 12 months of follow-up, after cryoballoon ablation, complete freedom from arrhythmia was achieved in 64.7% of patients with a common venous trunk and in 69.2% of patients in the control group. There was no significant difference in event-free survival as shown by the Kaplan-Meier curve and the log-rank test. For radiofrequency ablation, success rates at 12 months were 72% and 76.2% with common venous trunk and in a control group, respectively. So there wasn't a significant difference between the two groups. Thus, we can conclude that the prevalence of left common pulmonary vein was 20% in our institution during the study period, and there was no significant difference in procedural parameters such as procedural time, fluoroscopy time, and fluoroscopy dose between patients with a left common pulmonary vein and the control group. And no significant difference in atrial fibrillation recurrence was observed between patients with common pulmonary vein and the control group after either radiofrequency or cryoballoon ablation. Although the so-called single-shot devices, such as cryoballoon, were not developed exactly for common trunks, they are well suited for use in this population as well. And finally, I'd like to thank my colleagues at Göttingen National Cardiovascular Center for the opportunity and the high level of professional support and assistance. And thank you very much for your kind attention.
Early fertility knowledge and behavior among indigenous young women in Guatemala. Now I'm working in a research and development department in Norway, but before that I used to work in Central America for a health development project. So this study is based on my experience. And this study uses the kind of secondary data analysis to deduce the existing data set. The background or indigenous people in Guatemala. In Guatemala, and there exists high rates of inequality among indigenous and indigenous people, who comprises nearly 45% of the population. Many studies on indigenous women in Guatemala have focused on maternal and child health, but a few studies focus on adolescent and reproductive health, such as early fertility among young women, including rural and urban disparities. And generally, there exists huge rural-urban disparity in low-middle-income countries, including Guatemala. And in Guatemala, as I said, the 45% comprise the population of the indigenous, 45% of population as indigenous people. So some people, many indigenous also people live in urban area, not only rural area. So we need to consider the geographical factor when we conduct studies.
I'm really sorry to interrupt you, but we see just the first slide.
Okay. So I will try some.
So it's not in presentation mode, sorry.
Not the presentation. Okay, I will try with this. Now you see the whole presentation.
Yeah, perfect.
At the slideshow, yes.
Yeah.
I mean, yes. Okay, so the purpose of this study is to investigate the association mechanisms in influencing early fertility among young indigenous women in Guatemala using mediation analysis, and this to investigate the rural-urban disparities among indigenous and non-indigenous young women. Method and data source. This study uses the secondary data from Guatemalan Demographic Health Survey or Encuesta Nacional de Salud Materno-Infantil. The samples are women aged 20 to 24 years old in Guatemala, which was divided to 4 groups, which is non-indigenous women in urban area, indigenous women in urban area, non-indigenous women in rural area, and indigenous women in rural area. Data analysis. The 2 data analysis methods were used. First, pairwise comparisons was conducted among all 4 groups. And second, partial least square structure equation modeling was conducted among 3 groups. So here, first I will call the PLS, the partial least square, the PLS to make it shorter. And I will explain a bit about the PLS. PLS is a combination of multiple regression analysis and factor analysis. Or this is an extension version of multiple regression analysis and examine mediating association in addition to the direct association between predictors and outcome. Also, PLS uses latent variable as a kind of a part of factor analysis. And latent variables are unobserved variables that combine several observed or measured variables. Model development for this study. A hypothetical model analysis was developed based on existing health behavior change models and theories. And the model for this study consists of 4 levels. The first outcome level and exogenous variables, and 2 levels of mediators in between. In PLS analysis, the term exogenous variable is used instead of independent variable. Okay, so exogenous variable or independent variable, there are 4 variables, which are media exposure, which is latent variable with 3 measured variables, and highest education level, literacy, and wealth index uses measured variables only. Outcome is early fertility, and latent variable consisted of 2 measured variables. Mediators. First level of mediators consists of 3 variables. All 3 variables are latent variables on attitudes and knowledge on pregnancy prevention, on contraceptive use, and attitudes toward gender-based violence. A second level of mediator are 2 variables. The actual contraceptive use was measured variable, and risky sexual behavior is a latent variable with 2 measured variables. Results and discussion of findings. There are 3 main findings from this study. First, early fertility among indigenous people in rural area is influenced by more factors than those among non-indigenous people in rural area and indigenous in urban area. These findings was drawn from the results of PLS analysis, or the direct and mediating association that is shown in this figure. In this figure, if there is a line or the path between variables, that means that there is a significant association between variables. And if there is no path between variables, that means that there is no significant association. And path with red color means that there was a mediation association path between exogenous variables or independent variable and outcome. So as clear in those figures, indigenous women in rural area, the group in indigenous women in rural area has the biggest number of both direct and mediating association with outcomes, showing that early fertility among indigenous people in rural area is influenced by more factors than those other groups. Second findings, geographic factor has stronger influence than ethnicity. These findings was drawn from descriptive pairwise comparison and PLS analysis. This figure shows the pairwise multiple comparison of variables among 4 groups. And the table shows values shown in this table are p-value. As shown in the red highlighted columns, there are statistically significant differences in all variable or all but 3 variables between indigenous people who live in urban area and indigenous people who live in rural area, as well as non-indigenous people who live in urban area or non-indigenous people who live in a rural area. This means that between the same ethnic group but live in different residence area. On the other hand, and shown in the light blue highlighted columns, around 40% variables were not significant between the groups living in the same residence area or urban or rural, but different ethnic group. And PLS analysis showed also similar association patterns between indigenous and non-indigenous women both living in rural area, compared with those between urban indigenous people who live in urban area also and rural area, or the indigenous woman living either urban or rural area. So both pairwise comparison and PLS analysis shows the geographical factors have stronger influence to early fertility than ethnicity. Third findings, having better knowledge or attitude toward contraceptive use did not really reduce sexual risk behavior or increase the condom use. This findings was drawn from the result on PLS analysis that shows a competitive mediator. Competitive mediator or competitive mediating association means that the mediating association and the direct association points to in the opposite direction. As the example shows that the left figure in this slide shows that path coefficient on direct association between education and sexual behavior is positive, while the path coefficient on the indirect association via contraceptive use is minus, because plus multiple minus negative, positive and negative become negative coefficient value. So this was assumed that some factors underline the path between attitude and knowledge contraceptive and sexual behavior around this this path would influence the competitive mediation. One of the explanations is whether women have a power of actual decision-making on preventing risky sexual behavior and contraceptive use. For example, in Latin America, machismo, a set of beliefs that men are superior to women, is prevalent, including Guatemala, regardless of ethnicity. So machismo can be one of the reasons that women cannot have actual decision-making on preventing risky sexual behaviors, although the women have enough knowledge of contraceptive methods. However, this study used the existing data set and did not include the data, and those data sets did not include the variable indicators on which the man or woman made an actual decision related to prevention of risky sexual behaviors. So it will be suggested to investigate the actual decision-making power of women related in risky sexual behavior. So conclusion. This study introduced the concept of mediators by using PLS analysis to investigate association mechanisms influencing early fertility among young indigenous women in Guatemala. Early fertility among indigenous people in rural areas is associated with more influential factor than that in non-indigenous people in rural area and indigenous in urban area. For example, media exposure, attitude, knowledge on pregnancy prevention, contraceptive use, in addition to the education and risky health sexual behaviors. So improvement of those factors among indigenous young women in rural area is suggested to reduce early fertility. At the same time, a geographic factor had stronger influence than ethnicity among young women in Guatemala. So reducing geographical gap is also important. The further discussion on elaboration of variables measuring the actual decision-making related to risky sexual behavior are just suggested. Due to the use of existing dataset, there was a limitation in selecting the variables related to attitude and sexual behavior, especially variables measuring the actual decision-making related to risky sexual behaviors. Okay, thank you very much for the presentation. And I just want to mention that the pictures shown here are the one that I took, the picture that I took when I was working in the health redevelopment project in Guatemala. Also targeted for indigenous people, of course. Thank you.
Thank you, Dr. Hansen, for a great presentation. If anybody has any questions, please go ahead.
By training, and my fieldwork research is in Japan. So recent multi-species ethnographic works have challenged the anthropocentric understanding of agency and applied agency to non-humans, most notably non-human animals. An even more radical school has argued against abiotic prejudice and suggested that aliveness is not necessarily a prerequisite to expressing agency. Anthropologists have long been aware that most societies also apply agency to non-living non-humans, such as spirits, ancestors, the dead, and gods. Some researchers extend the term liveliness even to chemical species, such as rocks or weather systems. However, if we continue to broaden the term agency, does it not at some point lose specificity and become arbitrary and thus no longer useful for academic discussions? Furthermore, should there not be a difference between humans attributing agency to a being and these beings having an inherent ability to express agency? If so, how would we know if we cannot even enter the minds of other humans, let alone those of non-humans? So in this presentation, I want to discuss these questions using the example of a humanoid robot named Pepper that is used in elder care homes in Japan. The results from the fieldwork I conducted in 2019 suggest that elderly people develop an emotional attachment to such devices by attributing agency to them. I argue that robots, as their machine learning routines grow more sophisticated, will eventually interact in such a way with humans that the dichotomy between attributed and inherent non-human agency becomes meaningless. So humanoid robots are still rare in most Western countries. However, in Japan, their usage has increased drastically in recent years. As a hyper-aging society with one of the highest life expectancies in the world, Japan is currently undergoing a demographic transition that Western nations have yet to experience, showing us possible avenues for our own future. As the population has aged, the workforce has shrunk, leaving the increasing elderly Japanese population with an insufficient number of caregivers to meet their needs. Hoping that robots will fill this growing gap in the workforce, Japanese authorities have sought to introduce robotic devices that can perform some of the needed work. Despite the enthusiasm with which the Japanese government is encouraging robotic solutions to solve the elder care labor shortage, the introduction of social robots into the realm of care might be considered contentious. The potential problem is that while these devices may fulfill all the outwardly necessary requirements that are essential for the provision of care, they can only express algorithms that imitate feelings. These machines speak and appear to listen, and by interacting with them, we appear to attribute a humanistic nature to objects that have none. In this ethnographic excerpt, I present a brief interaction between an elderly woman, Eriko, who resides in a Tokyo public nursing home, and the humanoid social robot, Pepper. This new mode of social interaction is used to discuss the non-human agency of social robots. And I propose that Luisa Damiano and Paul Dumichel's affective loop approach as a processual type of agency can help to better comprehend the human-robot interaction involving the quasi-other social robot and the emotions and feelings it generates in the human. As seen in this excerpt, Eriko seems to believe that Pepper is somewhat alive, but she had trouble articulating exactly how she felt that the robotic device is alive. The AI functions embedded in the robot are able to execute numerous functions that a toy cannot, and perhaps these are what make the robot appear to be somewhat alive. Alternatively, maybe it is Eriko's own expression of authentic feelings toward Pepper that makes her perceive it as somehow alive. It would make no sense for Eriko, an adult with full cognitive capacities, to invest authentic social emotions in a lifeless toy, as children do with dolls. So the robot must be somewhat alive to protect Eriko's dignity. Moreover, Eriko's use of words such as him and really like shows that she does not view the robot as an object, but as some form of a quasi-other with the social reality she constructs, co-shaping the quasi-social relation. So as the descriptions from the field side illustrate, Eriko appears to be projecting a mind onto a non-human and attributes human cognitive abilities to Pepper in a process that enables her to regard a non-human as an other within a social interaction. The interaction between Pepper and Eriko compels us to rethink the role of non-human agency in regard to artificial abiotic devices that mimic social interactions and are thus perceived as somewhat alive. Now, this illusion of agency is exactly what developers of social robots are aiming for when they model social robots after us. Rather than seeing in the computer the model of the human mind, social robotics uses human social and cognitive competences as a model for the social and cognitive performances of artificial social agents. So I argue that the discussion of the possible agency of social robots can be viewed through the framework of multi-species ethnographical writing. Multi-species ethnography concentrates on the links between multiple organisms, humans, non-human animals, plants, and in this case, the artificial nature of social robots, while primarily focusing on comprehending humans' emergence as a result of these relations. This different outlook on what it is to be human can showcase an alternative set of ethics to live by in the world. And in order to achieve this, multi-species ethnography needs to present humanity's links with other species to stimulate new ways of thinking. In my reading of the literature, there are at least 3 different ways that non-human agency is commonly used in academic writing. So let's start with the first. First and most commonly is the linguistic or grammatical agency, and it is often used in conversation or writing to avoid a passive voice. So when I ask the woman, how does Pepper make you feel? The grammatical structure of the sentence indicates that Pepper is an independent actor that has the capacity to alter the emotions of Enrico. Now, this form of agency is seen quite often in not only everyday conversation, but also academic writing. For example, when an essay is started with the following statement, this essay argues. Now, in this last case, neither the author nor the reader will likely take this sentence literally, but regard it as simply a stylistic choice. Nevertheless, as language does shape our thinking, we cannot definitely say that it does not leave an unconscious impression on the receiver, especially in the case of Pepper, where the discussion itself was centered on whether the robot was alive or not. The phrasing of the question by me could have already influenced the perception of the woman and made her more likely to attribute agency to Pepper in the answers that she gave. A second way to use non-human agency is the attribution of agency to someone or something. So when she states that I really like Pepper and I hope he likes me back, the woman attributes agency to Pepper by alluding that it has the ability to like someone. Now, this form of non-human agency is encountered by many anthropologists in the field. While attributing agency is helpful when describing our ethnographic fields, there remains always the question of whom we as scholars should grant agency in our writing. Bruno Latour's actor network theory has already included abiotic actants in the analytical framework. Here, agency is completely decoupled from human characteristics. Rather, it asks whether an entity inside a network makes or promotes a change in another entity. The requirements for agency are lowered to such an extent that even a volcanic eruption would constitute agency, as other entities must react to it. However, this definition could lead to unsatisfactory results. In the end, the question remains as follows. Does Pepper only have agency insofar as Enrico attributes agency to him, or should we as researchers look for a deeper form of agency, one that transcends the mere outside attributions of such? And how would an academic definition of inherent agency differ from that of our research subjects? Or is every rationalization of inherent agency at best just a more sophisticated form of attributed agency? Now, lastly, the inherent agency of lifeless objects. In multi-species ethnographic writing, the theoretical framework that I mentioned earlier, it is largely uncontested that non-human animals, at least, are also inherent bearers of agency. More contested is the question of whether, under certain preconditions, inorganic matter could also have the ability to express agency. Unsurprisingly, not all anthropologists agree with such an open-ended interpretation of non-human agency. For example, the anthropologist Eduardo Kohn argues that things cannot be agents. He puts forward the notion that only living beings are selves, as only they can express thoughts and create a personal reality, allowing them to depict the world with symbols. In his interpretation, thoughts expressed in a symbolic language allow selves to learn from mistakes and react differently in a similar situation as a result of the learning process. For Kohn, there is a difference between attributing animacy to all types of entities, including abiotic ones, and recognizing the ontological reality that certain beings possess thought and are reacting to outside behavior. As he explains, representation, intentionality, and selfhood still need to be accounted for, and because the way such processes emerge and operate beyond the human is not theorized, Lutheranian science studies is forced to fall back on human-like forms of representation and intentionality as operative in the world beyond the human. Now, building on Kohn's work, I suggest that there is a third form of non-human agency writing, which I call inherent agency. So, sorry, I have to go back one slide here. Kohn argues that it is possible to see the intention of a self when it acts in a certain way because of experiences in the past and expectations of the future. So for me, this means that the bearer of an inherent agency must have the ability to learn from the past to intentionally change its future behavior. And it can do this because in its mind, it has created through mistakes and observations its own version of reality on which it bases its actions. However, here I must return to what anthropologist Marco Motta has called the skepticism of the other mind. How can we be sure, without the ability to enter other minds, that a self has a mind that is capable of learning? One indication is that the potential bearer of an inherent agency shows signs of attributing agency to other minds. Kohn offers an illuminating example of a scarecrow that I adapt to a recent occurrence in Takigawa City on the northern island of Hokkaido, Japan. After an increase in bear appearances near the village, farmers in Takigawa devised a ploy to deter bears in the future. They purchased a gigantic robotic device, which looks like a fearsome wolf, as you can see on the slide here, and has rudimentary motion abilities to deter the bears. The farmers hoped that the bear would mistake the device for a wolf and refrain from coming near the village. Indeed, no further bear sightings have been made since. No human looking at the picture of the robotic wolf would likely mistake it for a real wolf. But according to Kohn, the human perspective is also not the point. The robot is an attempt to imagine how a bear would see a wolf. Now, if the farmer's ploy worked, a bear seeing the robot would believe it to be a wolf that has the ability to harm it, and it would therefore exercise caution and avoid the area. In the scenario, both the farmer and the bear are bearers of an inherent agency, as the farmer attributes agency to the bear, that it would mistake a machine for a wolf, while the bear attributes agency to the wolf, believing it to be dangerous. Now, over time, the bear might eventually even figure out that the robot poses no danger and ignore all similar devices it encounters in the future. Meanwhile, the robotic wolf might have received attributed agency from the bear, but it does not hold inherent agency, as it cannot think or act independently. The problem with this example is, of course, that we cannot be sure what the bear really thinks. While the farmers believe that the new device is responsible for the lack of further bear sightings, the reasons for this change could be numerous and completely unrelated to the notion that bears have mistaken the robot for a wolf. Through careful observations and extrapolations, we can make educated guesses about whether others possess inherent agency, but we can never be completely sure. So let me now quickly return to Enrico and Pepper and discuss whether Pepper is more like the bear or the robotic wolf. Now, if we follow Kohn closely, I have concluded that Pepper is not a living being and therefore cannot be counted as a self, thus disqualifying it from expressing inherent agency. However, if we only look at Pepper's behavior, the case becomes less clear-cut. In a direct conversation, Pepper reacts in a seemingly meaningful way to Enrico's inquiries and thus passes the Turing test. This interaction causes confusion, for Eriko, as on the one hand, she's aware that Pepper is only a machine, while on the other hand, engaging in a meaningful conversation has, throughout her life, been a clear indication of encountering another self. Eriko partially suspends her skepticism when she says that Pepper feels alive. So since we might best understand Pepper as having a form of distributed agency, that is a processual type of agency, I return to the affective loop approach. Pepper has the ability to engage Eriko in a dynamic interaction that includes affective expressions and appropriate responses, and thereby triggering further reaction on the part of both the human and her artificial partner. As such, Pepper prompts Eriko to respond affectively and gradually to feel increasingly involved with it in a way that augments the social presence of the social robot and thus favors human-robot social interaction. Nevertheless, a longer and more critical interaction with Pepper might eventually destroy the illusion of another self when, for example, it becomes clear to her that Pepper is only able to react to outward stimuli in pre-programmed ways and fails to anticipate future questions or behaviors. Now, in conclusion, as AI based on machine learning progresses, it will become more difficult to destroy this illusion. The basis of machine learning is that we need to ask whether a program learns through millions of observations and mistakes to anticipate and react accurately to future events without relying on pre-programmed code. Now, in this way, machine learning comes very close to my former definition of inherent agency, as it constructs its own reality to face unknown challenges. Machines are already embedded within our lives, but as we start to treat machines as if they are almost human, we may begin to develop habits that will cause us to treat human beings as almost machines, and we need to consider not only what social robots are capable of doing now and in the future, but also what humans will become by increasingly forming such relationships with these machines. Thank you.
Thank you, Dr. Aronson. If anybody has any questions, please go ahead.
Far too many things are already going only over our heads, and perhaps the mind didn't want it. Our psyche works for the first time with our feelings and emotions. The rest is a lot of exposition and explanation. We are going now immediately to our hypophysis and trigger our amygdala and activate our left brain. It is this area of feelings, movement, and body language, and the art of mime. Well, this ability or the art of mime means wordless language, which is 93% of our signals. So the non-verbal communication. And that has more to do with our million years old limbic system than with our younger neocortex. The cohesion of our physical, sensual, and mental balance, this delicate mechanism, is not only possible through efficient breathing. It is. The various methods teach us to use this unrecognized power. Classical mime wants to reduce everything that is possible in its pure representation and express the balance between thinking and feeling in a minimalist way in order to convey the essence of a message in the best possible and artistic way. With concentrated, almost invisible, fine muscular strength, the mime unbelievably packs only what is necessary to allow deep human feelings to be experienced. He doesn't just show them, he experiences them himself, allowing his audience to share in them emotionally. And that we will try now. Unfortunately, I can't give you here a performance, but I can try to invite you to be like children now and still be astonished. Unfortunately, Wonder has been lost in our world. We are overfed and overwhelmed, frightened and mostly sublimate our worries. You know, certainly all the beautiful film, The Beauty and the Beast, isn't so? Well, you remember when the beauty comes in, there were sculptors. And I would like now that you are all doing that. You feel that you are a sculptor. And she's coming here from the right, you know, and just only your eyes are looking now on the right. I do it on the left, that you see that's on the right. And you follow the beauty what is coming in this castle. Oh, and the head is going. First the eyes, and then the head, and showing. Do all, please, all the same. And you feel in this beautiful big castle, beauty is coming. Hey, look. Only with your eyes. And she's far away now. And the sculptor put down the head again. This is a marvelous feeling to make a sculptor living. We are playing. We are not playing. We are working with our brains now, but the left part and the limbic system. And all that, what I did, is with a long breathing, one breathing, the whole thing, you know, until on the end, and then breathing out. So with the three chambers, the belly, the chest, and the back of the head. But that's another exercise. What is the expressive mime? Well, I would like to invite you now, immediately, by the first snow. And you feel you are children, and you're so happy for this first snow. And this part of your body now is moving. Not your hand, only the pulse. And yeah, please feel this snow is coming. Oh, yes, yes. Oh, yeah. Completely different if you would like to pick cherries. So now we are all trying to pick cherries. So you see the big tree. You want really now to eat them already. Now, what the happiness in your brain is unbelievable for the moment now. And you're going with your fingers, you see here? I taste it. Did you taste the cherry? Completely different if you see an apple. You want to pick the apple. It's not with your fingers now. It's with the whole hand and your fingers, you know, and then it's the water is coming in your mouth. Yeah. And then clack. No. Maybe you're very hungry. Maybe you feel the water is coming out. Taste the apple. You can't believe that a robot cannot do that. It's the whole body now, and the whole brain is busy only with this taste and this envy to do it, just to try it. And, you know, it's different in our all facial expression, but it's with the whole body we are doing it. we have a universal code for the mind, for the body language. It's universal in the whole world, the same. And nobody knows that. But you know Leonardo da Vinci. So vertical upwards. With the hands, with the arms, this is light. This is air. This is sky. This is father. This is mind. Vertical upwards. So when I'm doing that here, it means I'm thinking. I'm thinking. Oh, it's light. It's the sky. It's blue. Just the opposite is when I'm going vertically downwards. Heavy, fire, water, feelings, mother. How deeper the vertical gesture downwards, the feelings become great emotions. Horizontal left. This is my own past here. Here, my past, my future. So, but if we teach somebody, we are in the front and talking to somebody. We have to split. We have to mirror. So this is your future. And it is your past. I don't know if you see me in a mirror now, because this is my left side and it is your right side. So this is your future, but it's my past. Very complicated what the brains are doing, but we see it immediately. We understand people in the front of us. Aha. And they are thinking about the mind. It is something light. It's the father. It's the brain. No, it's heavy. It's emotion. It's the mother. It's the past. It's the future. Is that not fantastic? Is that not unbelievable? So maybe you are scientific people. You are from the medicine. Try to do it in a scientific way to analyze what's happening here in our brain. These million and million of limbic system. It's so beautiful to communicate again naturally with each other. I hope you enjoy it, and I thank you very much. Jean-Marie Botquin, living in Munich, Germany.
Thank you, Dr. Botquin, for the amazing presentation. If anybody has any questions, please go ahead.
So we're going to be looking at what is health in all policies, the focus of the research, and then going into the research itself and the lessons learned and extrapolations. So what is health in all policies, or HiAP? Health in all policies is a European-based policy mechanism. It employs a systematic approach based on population behavior, social sciences, and both the need and influence of health on policies. Specifically, the strategy is to work horizontally across government sectors and not just in health to ensure that health is in every policy. The goal is a prioritization of health, usually with a specific metric being targeted. For instance, the first iteration was in Finland. They focused on reducing the prevalence of cardiovascular heart disease, or CHD, and obesity. In the 1970s, they launched a project with health in all policies as its framework. Finland invested in intersectoral collaboration, integrating into existing policies, and focused on epidemiology and social determinants of health. They were able to revitalize health, resulting in a 75% decrease in CHD mortality rate. Due to the multifaceted nature of the policy changes made, the population's use of butter on bread also dropped from 90% to 5% between 1972 and 2009. Health in all policy mechanisms result in better, more informed policymaking that can innovatively decrease burden of disease on the population. This figure demonstrates the policy considerations and processes in coordinating efforts from a number of sectors of society to accomplish the health outcomes desired. Looking at the Spanish example, not more than 50 years ago, Spain was held tightly under control of conservative dictatorship. Since becoming a democratic regime in 1978, Spain has achieved substantial health outcomes with impressive decreases in mortality rates and increases in life expectancy as compared to other countries in the European Union. For instance, in 2015, Spain had the highest life expectancy in the EU with an average of 83 years compared to that of 80.6 years of the EU. This is very powerful as Spanish GDP health expenditure is less than that of the EU average. These dramatic improvements are attributed to Spain's national healthcare system, which has made these strides for a shockingly low price tag. Spain spends 3.5 times less than the US on healthcare despite being a public system. Due to systemic efficiencies also, Spain has been considered a model for newly industrialized countries to create an affordable and national healthcare that addresses determinants. Nonetheless, certain regions in Spain perform exceptionally more robustly because they utilize holistic approaches due to the ability of the autonomous communities to control over expenditure, levying taxes, healthcare, and reallocation of funds. So the question is why and how are these healthcare successes achieved? So in this research, I reviewed 36 sources, and I also traveled to Barcelona, Valencia, and Madrid to conduct semi-structured interviews in Spanish with government and healthcare officials. I used rapid qualitative analysis that I integrated into the literature review and then wrote the paper. So our findings. The biggest thing is that we focus on people and their needs. Catalonia has assumed a singular approach based on the health and all policy model, which has proven very effective. In particular, they step outside of the traditional roles of government oversight to forecast visionary policy-making techniques. One path that has been implemented in Catalonia is Pla Interdepartamental y Intersectorial de Salud Pública, or PINSAP, which was first introduced in 2009 and has since then had more iterations. PINSAP stresses the importance of developing policies that prioritize health and improving lives from multiple standpoints. In 2016, the Catalonian government approved policy legislature to incorporate a national sustainable development goals plan and ensure that the targets listed in the 2030 Sustainable Development Goals agenda are incorporated in Catalonia. As such, PINSAP seeks to optimize the health of the population, the creation of public health policies, and initiatives designed for health promotion. Its main focus is to emphasize the role of governance for health at different levels and not just a generalized national health care. By integrating health into every policy put forth, Catalonia ensured that decision-making prioritizes citizen health first and foremost. When all shareholders are on the same plane, better conversations can be facilitated to better avoid potential issues. Backed by the WHO, the most up-to-date PINSAP includes multiple objectives for implementation. They have the priority to engage all levels of government and society to positively influence health. This follows the 17 Sustainable Development Goals to ensure sustainability and equity. Next, PINSAP looked to coordinate efforts amongst department plans on all levels. They acknowledged the individuality of different zones within the region and encouraged utilization of resources in each zone that best reflects the needs of the people in the area. With that in mind, PINSAP bolsters community health projects to improve all communities within Catalonia. This ensures that not just a few communities are cared for, but that all are to improve life. In order to promote a healthier Catalonia, over 14 actions and programs have been introduced that have greatly improved the Catalonian lifestyle. More specifically, one of the most impressive reforms is the nutrition program. Spain ranks 9th in the world of the 28 countries that have implemented sugar taxes worldwide. Specifically, Catalonia passed Law 5/2017 as a means to regulate sugary beverages. Furthermore, studies have demonstrated the success of a Mediterranean-based diet. As such, the government, through a program coined AMED, has aided in the accreditation of 500 plus establishments and 95% of hospitals to adopt a Mediterranean diet. Specifically, the government has implemented healthier meals in cafeterias and schools and factories, and that this gives more nutritious options for these populations. Another tenet of this program is the concept of más cambia a or menos. This also in English means more, change to, less, which is in accordance with the policy instructed by the 17 Sustainable Development Goals. This was branded as small changes to eat better. This beneficial and instructive information clearly demonstrates nutrition simplistically so that the citizens can easily understand and utilize it to improve their dietary habits. This engaging resource facilitates a conversation of the power of placing health first. This policy and its philosophy has positively changed the nutritional outcomes for school children and factory workers. They've begun to furthermore to prescribe exercise as a form of treatment for certain diagnoses. This activity-based prescription, instead of pharmaceutical, has manifested in a program called FitJove, and there exist pilot programs in multiple Catalonian municipalities. Additionally, this idea exists outside the healthcare sector and promoted in the social prescription program, where social activities and community participation are prescribed to promote quality of life with positive mental health. The government works with the social enrichment and public zoning sectors to build free outdoor gyms, as you can see in these pictures, and public spaces to further impart awareness, accessibility, and engagement for the population. In this table, we see that from the PINSAP policies that extend from the Catalonian government to the localized program that are horizontal in measure, the healthcare outcomes have vastly improved across multiple sectors. As you can see in the table, life expectancy has improved, as well as mortality per 1,000 inhabitants and tobacco consumption. Nevertheless, there are, of course, key issues at language, such as obesity. Obesity is influenced by many factors, including social and environmental effects. In response to this weight epidemic, the Catalonian government has responded on multiple levels. They've introduced taxes on select unhealthy foods, such as the sugar tax that we talked about earlier, improving public transportation, increasing education around obesity and nutrition, and working alongside architectural authorities to control and diminish the prevalence of obesity in society. So the question is, what lessons have we learned from this? First is the intersectoral approach. Health is and is always an aspect of life that interweaves all other socioeconomic factors. Policy changes must be introduced to improve communication and coordination, thereby introducing horizontal collaborative partnerships across government sectors. There is an accountability that exists as a main tenet of health in all policies. Understanding health as a priority. The first measure of implementation towards a better healthcare system is aligning the vision and actions of policymakers, whilst underscoring prevalence of healthcare and policy and decisions. It has been found that when health is improved, education is more readily accessed, income security is improved, and unemployment and social exclusion is reduced. This enhances capacity building and creates more proactive conversations about health. Win-win strategies. Policymakers must take into account the agenda of each stakeholder, shared objectives, and what instrumentation is available for operationalization. This step is built on respect amongst policymakers with the knowledge that a reciprocal relationship is beneficial. Furthermore, without each conciliatory shareholder contributing to improved healthcare policy, or if certain agents act as free riders without reaping the benefits without aiding themselves, health and all policy will fail. Therefore, once again, accountability is paramount to success. There are, of course, prevailing challenges with something like a health and all policy model. Larger scale implementation would require a willingness to coordinate human resources and the planning of fiscal resources, and therefore needs and contribution on both vertical and horizontal planes of government and power. The tenets of health and all policy acknowledges and works with prevailing inequities, but may be difficult to sustain on a grand scale. While it has been successful in a number of regions and different smaller countries like Finland, larger health systems are often entrenched in a battle of delivering healthcare and bureaucracy. Through the aforementioned implementation techniques, health and all policy can be realized and successful in serving a population. So extrapolation, how can we utilize this in other countries? We must engage the local community, revise health reporting, create sustainable changes, build bridges, and prioritize health. For a step in this direction, it is necessary to introduce or revise health reporting systems to understand precisely where regions are lagging concerning health outcomes. Attaining the next level of health outcomes could require a significant upheaval to the current status quo and policy perspectives, but a health and all policy approach could be what is necessary in order to sustainably bridge science, care, and policy. Thus, determinants can be addressed proactively by enabling the system to predict health outcomes and consequences of policies, thereby reducing not only the amount of trial and error, but also the expenditure on health. These lessons can provide directionality for other healthcare systems. If other countries employ a model that works across sectors and champions its population needs, citizens will have a better quality of life, translating in all aspects of life, including an increased productivity. And it may reduce inefficiencies in spending in government on the long term. Championing policy structures based on the Catalonian health and all policy model will increase dialogue surrounding the pertinence of health. A reformed policymaking process will materialize in effective coordination tactics where every key component is involved during policymaking processes. Ultimately, a health and all policy model allows for optimal experimentation, evaluation, planning, communication, efficiency, and policy decisions that directly involve and reflect the regional population and ultimately uplift the national healthcare system. By no means will inequities or inequalities disappear overnight. Each country must action a successful policy process where all shareholders can and will contribute, benefiting from the win-win strategies I mentioned earlier. In summary, in order to facilitate a holistic process across all regions, from the individual citizen to the national government, the visionary Catalonian healthcare policy should and can be extrapolated to subsequently be successful in implementing life-improving health outcomes on a broader scale. Thank you so much to the Richter Scholar Research Grant, which funded this research when I was in my undergraduate at Wake Forest University in the United States. Thank you to Carmen Cabezas Peña and Gemma Miranda. And thank you, of course, to this conference on the global healthcare and nutrition that allowed me to present this today. Here we see the link if you'd like to scan this or see this later. This is the link to the full research as well as my LinkedIn if you'd like to speak at all later. Thank you very much, and I look forward to any questions should you have them.
Thank you so much, Dr. Strelzer. If anyone has any questions, please go ahead.
The general practice specialist, Morphe.
Good morning to everyone. Today, I want to explain our project about quaternary prevention and hypermedicalization and about fragility disease and mobbing. Approximately 15–20% of patient-doctor meetings are defined by the latter as difficult. Difficult patients are defined as those who elicit strong negative emotion for their physicians. If not acknowledged and managed correctly, these feelings can lead to diagnostic errors, unpleasant confrontation, and troublesome complaints and legal claims. So there are no difficult patients, but difficult relationships due to characteristics of the patient, the doctor, or influences of society. In the second and third slide, we can see different tables which administrate attending general medicine course. The aims of the study is evaluating the relationship of the difficult patient with the over-medicalization and how much it can affect the clinical practice and public. Material and methods, work group of the vocational training of general practice of Umbria Region has developed from on difficult patient and over-medicalization, which was administered to doctors who attended the general practice. In this table, we can see the questionnaire which was submitted to 121 doctors attending the specific train course in general medicine. In this table, and in particular in the first column, we can see different types of patient: hypochondriac, non-collaborating, psychological, non-medical source, excessive medical appeal, exigent, suspicious, lie, and other. In the second column, we found the number about each patient. In particular, in the first line, we have with 97.5% hypochondriac patient, followed by not collaborating, excessive medical appeal, and non-medical source with 95.9%. In the third column, we have excessive and inadequate use of health services. And we found which 51.2% excessive about excess of medicine causes damage to health. We found not collaborating with 28.9%, followed by psychological with 24.8%, and followed by suspicious for 24%. Finally, here we have use of validated medical practice where the benefits are not clear, potentially harmful, and cause of waste. We found non-medical sources for 51.2%, followed by not collaborating with 32.2%. In this table, we can see 4 different definitions of veterinary prevention, but the most doctor answered correctly with 76.9% like action taken to identify patients at risk of over-medicalization to protect them from an aggressive medical approach and suggest interventions that are ethically acceptable. In this table, in the first part, we found pathologies in which we can find the over-medicalization. In particular, we found chronic degenerative disease with 35.5%, followed by acute disease and cancer. The second part, we found pathologies for which there is an evidence of overdiagnosis. We have dementia with 42.2%, followed by hypertensive heart disease with 30.9%, and followed by major depression with 32.2%. Here we can see the causes of sovra-medicalization, and in particular with 60.3%, we found lack of integration between MMG and specialist, followed by defensive medicine with 58.7%, followed by competence supports the pressing rate of patients with 55.4%, followed by mass media pressure with 36.4%, and finally followed by economic reason with 33.1%, like industrial pressure, professional interest, and social cultural. In this graph, we have underlined through our study that quaternary prevention can be linked to disease, to illness pathologies, but we have a greater consumption caused by pathologies that are poorly codified or by LUBI, like defensive medicine or mass media pressure. Stable, so we understand that quaternary prevention has many limitations, and so it takes a lot of studies to improve our ordinary work. We present a table to improve the health system. About some advantage, for example, we can have implement in the last years of university the practical internship of the general practice, or coordinate the execution of examination and therapies in comorbidities, adoption of standardized protocols, and telemedicine, for example, clearly after internship and practical medicine. About conclusion, it emerged that from the observation of the colleagues, collaboration between the various health figures, general practice, and specialists is opportune to better identify the different. So I have finished. I hope that it was interesting. Thank you.
Thank you, Rosaria, and thank you, Dr. Colucci, for the amazing presentation. If anybody has any questions, please go ahead.
So here's the overview. I've introduced the concept of large language models, healthcare training topics, large language model applications and challenges in healthcare, and the future perspectives. So to start with, what are large language models? So large language models are advanced AI algorithms focused on processing human languages by using deep learning and vast text datasets, make them a key part of natural language processing, which is also called NLP. You can find the development milestones of NLP. starting by 2013 from the graph. During 2014 to 2018, Google introduced the word-to vector, sequence-to-sequence transformer, and the BERT framework. And later, OpenAI's GPT-2 and GPT-3, released in 2019 and 2020, respectively, marked a new era in AI's text generation capabilities. And then ChatGPT came out in 2022, further bridged the gap between human and AI communication, making interaction more seamless and natural. And nowadays, in a real sense, the most applicable language models are GPT 4.0 from OpenAI, BART from Google, and Cloud 2 from Anthropic, and Llama from Meta. So, in the graph, in our examination of contemporary healthcare, we identify several key aspects that have undergone extensive investigation, yet continue to offer extensive opportunities for future exploration. The personalized treatment plan, digital health records, patient data analytics, medical regulations, patient interactions, global health monitoring, professional medication education, enhancing diagnostics. Okay, now let's think about how the large language models can be applied in healthcare, especially for those aspects mentioned in the last slide. For the medical text, related tasks like data management, medical documentation generation, health literature review, professional education, it can easily convert unstructured data into structured data for easier reading or further processing with the help of large language model. For the multimodal medical data, the large language model could also be beneficial by joint text and image analysis from symptoms and patients' histories to provide quick diagnosis instead of waiting days or weeks. And additionally, they can enhance the communication across the language barriers and help patients understand the medical information more clearly. So that's the power of the large language model. Okay, so nowadays, the large language models are more integrated with the healthcare system in the form of chatbots. So typically, this kind of chatbot system consists of several key modules like the natural language understanding, knowledge base, dialogue management, sentiment analysis, personalization, multimodal interaction. So consider the example from film Big Hero 6, where the character Baymax introduces itself with a line. Hello, I'm Baymax, your personal healthcare companion. How can I help you? So in response, the protagonist, hero, simply has to issue a request in the format of, hey, Baymax, could you? Based on this request, Baymax then activates the relevant subsystems to provide an appropriate response. And this interaction exemplifies the concept of prompting in the context of large language models. Since LLM typically operates as a black box, researchers and end users must craft specific prompts to elicit the desired responses. And the effectiveness of the interaction largely depends on how accurately these prompts are formulated to guide the LLM towards to the intended output. Okay, so turning our attention to some real-world implementations, let's discuss the MedPalm, a substantial large language model with 540 billion parameters developed by Google. This model is specifically designed to deliver high-quality responses to medical inquiries. Remarkably, the MedPalm has demonstrated an impressive accuracy rate of 86.5% on questions styled after the United States medical licensing examination. And MedPalm is distinguished by its ability to generate detailed, useful long-form answers to consumer health questions. And these responses have been rigorously evaluated and validated by panels of physicians and users for their accuracy and utility. Looking towards to the future, there is a potential for MedPalm to surpass human performance in certain aspects, representing a significant advancement in AI-driven healthcare solutions. And this one, in my research conducted earlier this year, I focused on utilizing ChatGPT, which is also large language model, to autonomously connect information from patients and generate useful medical case reports without the need for direct intervention by medical professionals. And throughout the experimental phase, the ChatGPT demonstrated the ability to accurately extract essential information and produce precise responses guided by specific prompts with the implementation of a predefined structure for case reports and through multiple rounds of prompt tuning. And ChatGPT was able to produce transcripts that were reasonably accurate and detailed. And the third one. Okay, so you can see two figures in this slide. The figure on the left illustrates the telemedicine application Chat Doctor, which leverages the open source model Llama, fine-tuned with medical question and answer data from the actual cases from iClinic. Remarkably, this approach has achieved a precision rate of 84.44%, slightly surpassing ChatGPT's 83.7% in similar tasks. And on the right, we observe the MedPalm's capabilities in interpreting medical images, and this system not only comprehends the content of the images, but also can provide detailed analysis and segmentation, showcasing its advanced functionality. And while there are numerous other explorations and implementations in the field, space constraints limit their inclusions in this presentation. However, it's important to note that these examples represent only a fraction of the potential applications and advancements being made with LLMs in the healthcare. So, aforementioned applications highlight the considerable potential of large language models in enhancing healthcare services. The large language models significantly improve the speed and accuracy of clinical documentation and data entry. And additionally, they facilitate the extraction and the synthesis of information, playing a crucial role in decision-making processes through advanced language analysis. However, it's imperative to acknowledge that the large language models in healthcare are not without their challenges. So there's something needs to be think about. Firstly, the data privacy, the safety and the adequacy of measures in place to protect the patient privacy, and the potential for biases in responses generated by these models. And lastly, the operational transparency of these models, particularly in terms of compliance with existing healthcare regulations and standards. And those problems are not easy to solve, and probably in a long time, people will keep working on that. Okay, the last one. So I'm quite confident that in the near future, the large language models will play an integral role in transforming the traditional healthcare. Their impact will extend far beyond just a few areas, we are looking at a future where large language models contribute significantly to advanced personalization, offering bespoke healthcare solutions tailored to individual needs. They are posed to enhance the diagnostic tools, providing more accurate and nuanced diagnosis. In telemedicine, large language models promise to facilitate smoother and more efficient patient-provider interactions, and their integration with smart wearables will enable real-time health monitoring and insights in surgical and rehabilitation robotics. The large language models can offer precision and adaptability. They hold the potential to revolutionize the clinical trials and the research, making these processes more efficient. And the large language model will also support augmented decision making, providing clinicians with data-driven insights. Additionally, their role in automated health education will be pivotal in disseminating personalized health information. And lastly, the development of ethical AI frameworks will ensure these advancements are implemented with responsibility and with equity. And this is a reference. Thank you. Any questions?
Thank you so much for your presentation. If anybody has any questions, please go ahead.
This morning, and as we know, with the ever increasing global world, bilinguality is prevalent in all areas of life, including health and medicine. What I'm going to talk about is a series of studies that was done in the past few years about bilinguality and code switching. Let's first define our concepts. Bilinguality is defined as a capability to speak more than one language. There are different kinds of bilinguality. Simultaneous is when you learn both languages during childhood at the same time. Sequential is when one learns one language first and then the second language is learned slightly later. And late bilinguality is when the second language is learned during the maybe high school or college years. In percentage-wise, all over the world, bilinguals are ever-increasing population, although historically, bilinguality was, even in the country I live, United States, was very prevalent, more prevalent than it is now. Currently, between 50 to 70% of the world's population are bilinguals, considered, and 66% of children. In Europe, it's about 56% of Europe, according to European Commission survey in 2006. Canada has 35%. Unfortunately, in the United States, the percentage ranges from 18 to 20%. Why should one be bilingual? What are the advantages? What are the disadvantages? Advantages of bilingual have been proven through scientific studies in the past 50, 60 years. One of the advantages is sustained attention. Bilinguals seem to be being able to pay attention closer to the task at hand. Inhibition, when a bilingual speaks one language, there are two languages in the brain that could be activated. The bilingual has to inhibit one language and release another. This capability to inhibit something, it's really helpful in doing all sorts of cognitive tasks and in life. Another one is, of course, a bilingual and monolingual switch between one language to another. So bilinguality helps you in switching from one cognitive task to another. And bilinguals are also seem to be slightly better in managing distraction, and they seem to be having better attentional control as they grow older. This results in one, they seem to have a slightly better academic achievement. And for bilinguals, just like monolinguals, do get a dementia. However, because of the more robustly exercised brain, there seems to be the signs of dementia, even though the brain structures are equally damaged as monolinguals. Bilinguals show these signs much later. Some of the studies show as late as 5 years later. In addition, bilinguals seem to have cognitive mechanisms that seems to be structurally slightly changing the brain, which in turn enables them to be better at cognitive tasks. And also they have the ability to communicate with diverse groups, which is obviously being able to speak more than one language enables you to communicate with more people. Finally, they seem to do better in jobs and travel as a result of capability to communicate with more people. What are the disadvantages of bilinguality? Obviously, the bilinguals have 2 lexicons, 2 mental dictionaries. The size of each one of these is slightly smaller than monolinguals who only have 1. They have less, slower and less accurate naming pictures. Again, accessing 2 different mental dictionaries, sometimes it takes slightly longer. And also, when they are trying to retrieve a word, seems to be require a little more effort. Now, code switching. What is code switching? Code switching is defined as moving from one language to another. Could be a phrase, could be a clause, or complete conversation. More than a word, because a word does not count as code switching. That's code mixing. This is a strategy that is used among all languages, all bilinguals who speak all sorts of different languages all over the world. Why would someone code switch? There are many reasons for it. One would be if a bilingual doesn't know a word in one language, they utilize the other language. They sometimes need to paraphrase something to get their meaning across better. Or when there is no exact equivalent in one language versus another. So there are many of the Eastern languages that have words for dignity that are very much more subtle, honor, things like that are more subtle than some of the Western languages. The social reasons for it, why would you code switch, would be, one would be to exclude other people. So if you're having a private conversation in a public place, it is helpful to code switch to a language people around you don't understand, or wanting to include others. So there are other people walk in and you want to include them in the conversation. Sometimes it is a social tension when there is a conflict, and sometimes is a way to distance yourself. Especially some studies show some people tend to avoid cursing in their own first language, but they are more comfortable to do it in their second language, or talking about private matters. And then also utilizing 2 languages, it's a way to emphasize an important point. This is the first one of the studies that we've done about myself and my lab about code switching. What makes people code switch? Is it possible to cause code switching under laboratory condition? So to see what really brings it on in terms of the social code switching, not psycholinguistic. First is, and what are the factors, what are the backgrounds in one's linguistic history that makes a person more likely to code switch? Our first study was done in 2015. In the study, I came up with a design that myself and my lab have been utilizing a number of years. And that is, for the first study, there were 24 bilinguals. They were all Spanish, 4 men, 20 women. I work in a university that is about 60% women to 40% men. And especially in psychology department, there are more women than men. So that's why they kind of slightly skewed population. What we did, the design that was took place was that the participants are invited into a room. They are told that the interview is going to be purely in Spanish, and no word would be spoken in English. They are asked to participate only in Spanish and not to switch in English. Obviously, the participants have to be capable of bilingual enough to be able to sit through a half-hour interview. The questions that are asked are about their linguistic history, about their family history of language, and then what their work, their life, simple everyday conversations. About halfway through the interview, interview is interrupted by a monolingual person who does not speak Spanish, comes in, that ignores the participant, approaches the interviewer and asks them some questions. As you see, these are obviously not, these are my assistants, not participants, because it would not be ethical to show the participants. And then the person remains in the room. As you see, the young woman with the clipboards comes in, approaches the interviewer, asks the interviewer a number of questions in English, and then remains in the room without ever engaging the participant. After the completion of the interview, the participant completes an online 87-question, all in English questionnaire about, again, their linguistic history and all that. The interviews are recorded, audio tapes, video tape. The point of this is this: at what point the person who is told not to code switch starts code switching? Would it be after the interruption was done by a monolingual, so to including the monolingual in the conversation, or realizing, oh, the person who's interviewing me also speaks English? These are the kind of questions that they would get in the questionnaire. Some obvious one: do you speak a different language? All that, and how fluent they are, where did they learn the language, and how often do they speak the language? So the results show that 33% of the participants, in fact, code switched, although they were told not to. And this was all after the interruption. They seem to be, the code switchers seem to be older population, and also more likely to be community members, and the mothers were born in the U.S. That study just showed us it is technically proof of concept. It is possible to induce code switching under laboratory condition. Then we continued with another study in 2018. What if there is something about the Spanish language and culture that makes it specific that people are more likely to code switch? What if we try 4 different languages and see if the code switching can be induced in those languages? So we included the Spanish, but added French, German, and finally Arabic. Spanish, French, and German obviously are Proto-Indo-European languages, and Arabic is Afro-Asiatic language. For each group, there were 20 participants, and each interviewer was, just like the previous study, native-born, completely fluent speaker of language. We steered away from anybody who any interviewer whose language was a second language. We wanted, native-born German, native-born Arabic, native-born French, and Spanish. The same experimental technique was followed, and these are some of the information about the characteristics of the participants. For a Spanish, age ranged from 18 to 60, French 19 to 62, German 17 to 74, and Arabic speaker 20 to 52. And mean age and what percentage English was their second language, and what percentage their mother was born in the United States. The results show that, again, 10%, a smaller percentage of that previous study of Spanish speakers code switch, 55% of French, 20% of Arabic speakers, but none of the German speakers ever code switched during those interviews. Spanish speakers who code switched were again older age, and age of the language acquisition did not seem to make a difference. Or for Spanish, French, and Arabic, and there was non-significant, if it was code switch or non-code switch based on anything, age, fluency, comfort in speaking, or frequency of embarrassment in speaking in public. The conclusion of this study was that, seemed to be other languages we can induce code switching under laboratory condition, but not in German. And the puzzling aspect was why not German? Well, obviously, it is well established that German grammar is much more rigid and rule-based than most other languages. That may have something to do with that if you're believing the Worfian hypothesis, and that, sometimes the structure of the language influences the way that people think and interact with the world. This brings me to the most recent study that was conducted in 21. And this one, we went back to interviewing another group of subjects, this time only 52 Spanish bilinguals, but there is a difference in the design of this study. The question was, what if people, not Germans, but all the other speakers, just at random code switch, and there's nothing to do with the interruption or a monolingual being present in the room? So for this study, a controlled group was created. So the participants were assigned at random to the control or experimental group. The interviewer didn't know who is going to be in which group. Only one of the experimenters knew. And so with the group that was experimental, just like before, a monolingual coach, monolingual person, researcher enters the room, engages the interviewer in English, remains in the room until the end of the interview. For the control group, no one enters. The interview goes on just like from beginning to the end, and with no interruption. And these are the participant characteristics, 18 to 24, mean age. This one, we even stayed away from the community members. We tried to purely have students that were students at Queen's University, and they were 100% students. A percentage of male, female, again, in experimental and control group was very similar, and mothers born in United States was very similar. So we tried to keep everything, the same, except for one group was interrupted and another group wasn't. Post-interruption results showed that, again, experimental group, before the interruption, participants only code switched 12% among the experimental and 19% among the control group. Post-interruption, 38% in experimental and 4% in control groups. So obviously and significantly, interruption by a monolingual and remaining in the room somehow pushed the bilingual to code switch and use more English in their conversation. So based on all these three studies, clearly code switching can be induced in English, Arabic, and French speakers. It could not be induced among German speakers, and code switching took place significantly more often among Spanish speakers, and which were interrupted by a code switch by an experimenter and resulted in their code switching. Currently, my lab is conducting a study on German speakers among the students of the university with control to see, one, if we can replicate the results, past result, that Germans simply do not code switch, and two, if in fact, if there is any code switching, does it happen after the interruption or before the interruption? These are my sources and my gratitude to my students. Any questions? I will be very happy to answer.
Hello, yes, thank you for that, Dr. Hofstad. I actually do have a brief question. This has been very interesting. I'm just very speaker, and I think code switch.
Please. Very good. So the topic I would like to discuss today is a large lung abscess in a young female patient. So as we know, lung abscesses refer to a focal cavitary area in the parenchyma filled with purulent or necrotic material. Usually is the result of a microbial infection, and the way you would know it is based on clinical presentation and symptoms. So a lot of times lung abscesses are kind of categorized as primary or secondary. Primary is direct infection of the lung parenchyma, and usually this is the result of aspiration with organisms like Staphylococcus, Streptococcus, anaerobic bacteria, etc. Secondary lung abscesses, on the other hand, are the result of underlying lung conditions like bronchial obstruction by a tumor, septic emboli, or other host-related factors like impaired host defenses, immunity, etc. More recently, since 2019, the introduction of electronic cigarettes, we have seen a few case reports and cases of e-cigarettes being associated with the development of lung abscesses. So going into our case, we have a 21-year-old female with past medical history significant for anxiety, for which she takes an antidepressant, came to the emergency room with complaints of fever, cough, and left-sided pain. She didn't have any associated symptoms, including weight loss or night sweats or joint pains, new swelling, new rash, new lymphadenopathy, nothing of that sort. Sort of pertinent medical history is that about 2.5 weeks ago, she had what appeared to be a URI, which got better with conservative management. No history of sick contacts, no recent travel. She denied smoking tobacco products or consuming alcohol or other recreational substances. She did, however, endorse to using electronic cigarettes with nicotine for about 6 months prior to presentation. So her vitals, other than some mild sinus tachycardia on presentation, everything else was okay. Her physical exam showed some coarse lung sounds on auscultation on the left upper chest. And initially, a chest x-ray was obtained, which showed a cavitary left upper lobe consolidated opacity. And so subsequently, we obtained a computed tomography of the chest, which showed a complex loculated fluid and gas cavity in the left upper lobe, it was quite large, measuring up to 14.5 by 13.3 centimeters, with some adjacent airspace consolidation. The right lung looked okay, and the pleural space was okay as well. If you guys could look at the CAT scan, the CAT scan image on the left, that's the CT image on presentation. So her lab data was significant for leukocytosis, which was to be expected, and elevated inflammatory markers like ESR and C-reactive protein. Her urine drug screen was negative for other recreational substances, COVID, influenza, PCR testing, rapid respiratory viral panel testing was negative. We also obtained blood and sputum cultures, which were negative as well. Legionella, streptococcal urinary antigen was negative. Beta-D-glucan, galactomannan, HIV fourth generation testing, quantiferon tuberculosis test were also negative. Some people might know this fact. So Indiana, Ohio are endemic for some fungal infections like histoplasmosis, blastomycosis. So we obtained serologies for those as well, which were negative. So we admitted her, we started her on broad spectrum antibiotics, initially vancomycin and piperacillin tazobactam to cover broader microbes, and she started improving in a few days. We did have this concern of the cavity being very large if just antibiotic therapy would be enough. So we kind of discussed this with infectious diseases and CT surgery as well, and everybody kind of agreed to the fact that we should treat it with antibiotics first. And in case of any no responsive treatment or other complications along the way, then we would consider like a percutaneous aspiration. But otherwise, the recommended treatment for lung abscesses is a prolonged antibiotic therapy for at least 4 to 6 weeks. So we kind of went along with it. And so we started her on pretty broad spectrum IV antibiotics, switched her later to Augmentin on discharge. And she completed a 6-week total therapy with significant improvement. We obtained a repeat CAT scan around 4 to 5 weeks, and you can see the CAT scan image on the right, which shows improvement, like actual resolution of the air fluid level. She is left with a cavity, which I believe is to be expected when you have such a large cavity on presentation. And she had no fevers. Her appetite actually started improving. We recommended she stop using electronic cigarettes, which she did. So coming to the discussion part of it, we are all aware of lung abscesses. They are not extremely common in clinical practice, but they do happen. I think the most important, two most important things in this case are, one, what do you do for really large lung abscesses? Do you go ahead and consider interventions like, percutaneous drainage, etc., or do you stick to the usual antibiotic therapy for a longer duration? So we did some literature review to see what's the data behind it. And all the 99% of the studies actually support, going ahead with good antibiotic coverage for at least 4 to 6 weeks. And percutaneous drainage or chest tube drainage is still a second line approach. And you do them in cases where they are not really responding to your treatment. And the reason why it is considered a second line therapy is because they can have complications when you attempt interventions like that, including bronchopleural fistula, spillage to your pleural space, infection, etc. And coming to the second learning point in this case is, we were quite surprised how a healthy female would develop such a large lung abscess without any predisposing condition. So we were suspecting if her electronic cigarette use has something to do with it. So as we all know, using electronic cigarettes has a lot of pulmonary manifestations, and broadly it's termed as EVALI, electronic e-cigarette or vaping product use associated lung injury, initially recognized in 2019. And EVALI can include pulmonary manifestations like ARDS, acute eosinophilic pneumonia, hypersensitivity pneumonitis, organizing pneumonia, lipoid pneumonia, pneumothorax, pneumomediastinum, etc. There are some case reports where electronic cigarette use is associated with development of lung abscesses, and we hypothesized that would have had some role in the patient's development of lung abscess. Fortunately, the patient responded really well to antibiotic therapy without need for any any interventions. Yep. If anybody has any questions, I'll be happy to answer